Bwrdd Iechyd Prifysgol Nar yn Bevan. Good morning and welcome to today's meeting of the board. Welcome to those guests who are attending in person and coming in shortly, and those observing via live stream. Today's meeting will also be available for viewing via the YouTube channel of the Health Board. And I have apologies for absence from Helen Sweetland and Bill Robson. Are there any declarations of interest on anything on the agenda this morning? No? Could we go to 2.1? Could I ask if any member wishes to bring forward any item from the consent agenda for individual discussion? Are we content with it as it is? Yep, thank you. Update from Mayor. Well, if we can start with the regional collaboration that was directed by the Cabinet Secretary and is on the agenda this morning. The three chief executives and the chairs have held a number of meetings to progress the development of pan-regional working as requested by the Cabinet Secretary. The results of the discussions are on your agenda this morning. I think good progress has been made. We have invited, as you can see, Velindra and who's the other one? No, Paris. Sorry. To be associate members, as we either have services from them or provide services to them, and that seems to be all right. There was a bit of a fuss at one time about that, but that's been accepted as being logical and sensible. I've had three meetings of the chairs group at which we have discussed the new accountability arrangements that apply to boards under a letter that I've circulated to you about moving towards a more transparent NHS. You'll be ever so pleased to hear that we go first with the guinea pigs for the over. And what basically is being requested is that we go to Cardiff and are held to account by the Cabinet Secretary to make it much more accountable for the public, so that he's doing that in public. And it will really look at the performance framework and issues such as ambulance handovers and the national 6 goals from urgent and emergency care, and what we're doing about enabling planned care in a more effective way. I'm disappointed personally that there is nothing strategic on this agenda, because I think it's important, particularly for the public, to set out the results almost of our consultation, extensive consultation with them about what would make them feel healthier and well looked after. So I think we will still try and push for at least there to be a small and focused discussion on the strategy for the future and what we're trying to achieve for our population, because I think it's important for the communities that we serve. So we will see what that's like. We have also, as chairs, discussed the Wales Maternity and Neonatal Assurance Assessment, which is due to start imminently. We know now who is on the group of individuals who have national expertise in their respective fields. It will be led by the former Children's Commissioner. Their timescale is desperately tight. It's a good job that we've got so much information about our particular services. And it all arises, of course, from the concerns that are being expressed both in England and in Wales in respect of failures of services. So I don't know yet when they are coming to look at our services, but I will circulate a note to you as and when I find out. Sally Holland is somebody that we know well, who does listen and is reflective. And the people that they have chosen to to be part of this group do seem to have very good pedigree and know really what they're doing. So that's great. And any help and advice they can give us as a consequence of their assessment, we'll really be pleased to receive it. But it is a very tight timescale, so we have to obviously ensure that we can help them as much as humanly possible. We also have discussed as chairs the induction and training for board members because it's been somewhat haphazard for the past few years, and have commissioned HEIW to undertake a proper controlled induction programme review. They know what we need in the independent members to know and the executives to know as members of the board, and so they are drafting it for us. They're having a go at a training programme now with both executive and non-executive newly appointed directors to trial what they think might be more suitable. But I do think it's really important that we as chairs push that further. I had to attend obviously the meeting where I had to undertake chair's action relating to outpatient performance and the utilisation of the additional resources that we had. There were a number of issues that concerned me about this and the contract. So I have written to Welsh Government outlining my concerns, as you know, as you've received a copy of the letter that I've sent. In particular, the fact that there's no provision for paediatric patients in the insourcing contract, but we are overcoming that ourselves. But I have heard nothing yet. I seem to be doing an awful lot of independent member and deputy CEO and other interviews in the last week and 2 weeks. We have interviewed for the independent member for the local authority, as Richard is no longer here as our member, and we await the result of the decision by the Cabinet Secretary. I have to say that we had an excellent field. I'm very grateful to our local authority members and for putting forward such really good candidates for our considerations. It was really heartening. We have obviously had the appointment of the Deputy Chief Executive, of which we have circulated a note and congratulations. And I was the chair on the appointment panel for the Managing Director of NHS Wales P&I, Performance and Improvement. There were 2 of us from the Health Service on the panel, me and Suzanne, the Chief Executive, Cardiff. The other 7 were either Welsh Government or P&I itself. I had asked the chairs before what they wanted to see as characteristics from this individual and the behaviour patterns that they wanted them to emulate. So I was able to feed all that in to the appointment panel. We had 26 applicants by the time I got hold of them. There were 9 that we were asked to shortlist. I did ask for the whole list and went through them, and I thought, yeah, well, okay, we'll shortlist. We'll discuss a shortlist from these 9. 3 people were actually shortlisted, 2 actually turned up, and we await the decision. Hannah was fortunately representing us on the stakeholder group, and I think that by the sound of it, the stakeholder group and the panel were in accord on this instance. So that was all right. But we'll wait and see what happens. And finally, we had a royal visit to the the Grange Hospital 10 days ago. Her Royal Highness, the Princess Royal, came to see the work that's being undertaken in our maternity unit, especially looking at the care and improvements that we have made in terms of cultural awareness and management. I think she quite enjoyed it, and I've now received a letter from her lady in waiting, which I shall read to you. The Princess Royal has asked me to write and thank you for the opportunity to visit your maternity unit at the Grange University Hospital. It was a privilege to see firsthand the impressive facilities and to meet the dedicated staff of this newly amalgamated Centre for Maternity Services. A special note of appreciation must go to Mrs. Jane Beasley for her invaluable insight and expertise throughout the tour. Her knowledge and passion were evident, and her thoughtful guidance provided a rich and informative experience. Meeting the core maternity team and witnessing their commitment to delivering high-quality care was truly inspiring. Please convey Her Royal Highness's gratitude to all involved in organising and facilitating the visit. It was both enlightening and encouraging to see such service delivery in action. I think that's a smashing.
Yes.
Letter. Really nice. And such beautiful typing as well. You don't get that usually. But that was really nice of her, and I think everybody enjoyed it immensely. And she, accompanied, of course, by our Director of Nursing. And she was lovely, really. She spent a lot of time with the staff, with the patients, and with the groups of staff who had been assembled. So she was late going. She was very good. She was very nice. And thanks to the Royal College of Midwives for choosing us, because it was their visit, not ours. So they chose us. We didn't arrange it. They chose us. So thank you very much. Oh, well, they can say that now everything went off fine. So thank you. That's been my couple of months with a bit of a holiday strip chucked in the middle of it. Are there any questions? No? Thank you. Nicola.
Yeah, thank you. So just a brief update really on some of the priority areas that as we kind of approach the half year point, 25-26, which is unbelievable really that we're already at that point. And over the last few months there's been a real heavy focus on 3 areas specifically. And the chair briefly mentioned the kind of national planned care programme, which is to try to get 200,000 people off the waiting list across Wales, which for us is around 30 to 40,000 people. So there's a huge amount of work been going on across the health board, particularly around the outpatient contract and trying to get additional patients treated on weekends and evenings. And the teams have been working really hard. It's been up and running for a number of weeks now and is due to continue to kind of ramp up over the next month with a number of specialties. We started with ENT and it's been going really well so far. So I just want to kind of recognise the amount of work this is created, but great to get so many patients seen so quickly. But we continue to update on that over the next few months. The other one is the National Handover 45 initiative that's being led by Welsh Government. This is around trying to get all ambulances across Wales handed over and transferred into the emergency departments within 45 minutes. As you know, we've been working tirelessly on this agenda for a number of years in terms of trying to improve our ambulance handovers, particularly at the Grange Hospital. And we commenced our own programme called Your Next Patient, which is now in its 3rd week, which Leanne has kind of been freed up from some of her other duties to kind of really base herself a lot of the time in the Grange to really try and embed some of the change supported by the clinical executives. So there's been a huge undertaking where over a 6-week period we're trying to really get underneath the issues and make some sustainable change. We've seen some significant improvements during those first 2 weeks. And obviously there's a huge amount of work still going on to embed and sustain that, but we can update more on that later. And then the 3rd area, as you know, we've had a number of discussions about the financial position. We've been under particular financial pressure in the first 4 to 5 months. So there's been a huge amount of work undertaken over the last month in particular, working with the divisions to make sure we can identify further savings to deliver savings in line with the plan pretty much. So we've got a new savings plan, but we've still got the increased cost pressure has resulted in a forecast deficit being presented for month 5, and Rob will update that later in the finance report. But we've got more work to do on that as an area going into the winter. And on that point, we've already started the work planning for next year because we can't, we don't get much of a break from the IMTP being approved and then planning for the new year. And we're really working hard to align the IMTP with the strategy that we approved at the last meeting. and really build on our work around prevention, place-based care and digital in particular are areas we've identified as key priorities for focus next year. And there's a lot of focus nationally on the primary care plans and direction, and also planning for winter, for which obviously we're actively involved, and we got people on the winter plan on November. We want to miss the opportunity to promote the importance of vaccinations for winter. We've seen a downturn nationally last year, and for our health board, and we saw the impact of that in terms of the pressure that was faced on our services in the winter. So I just want to reinforce the importance for the public and our staff to get vaccinated, and we're doing a lot of work and trying to use new initiatives and new ways of making it easy for people to get their vaccinations ahead of winter. And then just two things to finish. We have launched the When You Smoke, I Smoke campaign. I know Tracy's been taking a lead on this, but really, kind of raising the profile of smoking and the impact and what we can do to support people. And then the other issue I wanted to pick up, so I had the privilege last week of opening the big conversation on sepsis. We held an all-day event where we had staff and the public and people who've had lived experience of sepsis coming together to really look at how we can make further changes and further improvements around this agenda. And it was a very powerful, emotional day, but real kind of impactful in terms of listening to people's stories and the power of that, and how we see that as well in the patient story. So that's it, and we got the official opening of the Bedford Health and Wellbeing Centre and the satellite radiotherapy unit coming up in the next month, so that'll be really positive as well. So I'll just leave it there then. Thank you, Chair.
Thank you. Any questions to Nicola?
Just a small question or clarification. In terms of the national handover, 45 minutes, I was just trying to figure out, because we are spread over 5 local authorities, geographical area and all that, how practical it is to really get the ambulance out there to a patient and then bringing the person in within that 45 minutes?
It's more that it's 45 minutes from the point they arrive at the hospital to coming into the emergency department, as opposed to the response. But the Welsh Ambulance Service is kind of designed to be able to respond to the different local authorities. They'll have stations kind of situated across the 5 local authorities. Obviously, it's more challenging in rural areas, such as Monmouth, for example, but they are designed to respond. So what we are monitoring alongside this is the response times of the ambulance getting the call and going to the patient, in addition to when they arrive at the hospital and come into the department. But the 45 minutes is when they arrive at the hospital, they come into the department within 45 minutes. The key targets that they monitor is an 8-minute from a very high risk call. So they call red. They've recently changed that for purple category. They should try to get to the patient in 8 minutes in about 65% of the time. Then also there's amber calls, which is still quite high risk calls, but less immediately life threatening, where we obviously are trying to improve our kind of response times. So we are monitoring both of those as we make an improvement, and we have been able to see some improvements where the time for the ambulance to get to the patient is improving as we hand over quicker at the hospital. But we're monitoring that closely to make sure we do have the impact with our community response.
Thank you.
Does that make sense?
Thank you. Thank you.
Any further questions on that? No. Thank you. We move to item 4.1, the patient experience presentation, and can I welcome Nikita Strong, the lead nurse for early gynecology assessment unit, and Rachel, who's been good enough to come and present their story to us this morning. We're very grateful for this. Thank you.
Just preface this by saying that Rachel's story is quite emotive, so I recognise people in the room may have their own experiences of the things Rachel's going to talk to, so I appreciate that will maybe difficult for some people, so I think it's just recognising that. Okay.
Hi, so my name is Nikita Stanges, and I'm the lead nurse currently for early pregnancy and emergency gynecology, and this is Rachel Robbins. I met Rachel when she actually made a complaint through Putting Things Right about her experience when she sadly experienced a miscarriage. She was very upset at the time when I first was introduced to her. But since her experience, she was really keen so that we could take her experience and learn from it, and try and make improvement to our services. So today is a kind of positive outworking of what happened after Rachel shared her story. So we started off by working with Talia Strange in the patient experience team, and making a patient experience video, which we'd like to show you to start today.
My name's Rachel and I'm a single mum to 2 living daughters at home. I previously have lost 2 children in the past. One was in 2010 and she was my first pregnancy. And obviously being a first time mum, you get all excited and you get this sense of overwhelming love. I ended up having my first scan at 12 weeks as normal, and something got picked up on that scan. And it wasn't good news. And unfortunately, the consultant had told me that you either carry on and let nature take its course, but we are pretty adamant that this baby is not going to survive. So I made that awful decision to terminate my pregnancy. The hardest decision I've ever had to make in my entire life. I know that I want to name her, so I named her Scarlett. I happened to get pregnant in 2023, and I just knew in my own mind, I was like, I just don't know if I can wait till 12 weeks for a scan. I'm too anxious, too nervous. I'll have a look around, see if anyone's doing some private scans. It was a reputable clinic that I chose. She said, unfortunately, she couldn't see a lot at that point. She could only see a gestational sac. So I went back 2 weeks later, she re-scanned me. She said, we can see a heartbeat. She didn't ask how many pregnancies I'd had in the past. She had asked how many living children I got at home. But then I had to fill in the gaps about Scarlett. I would have thought possibly there could have been rules for giving me an early pregnancy scan, but that wasn't offered. I was just told you have to wait your 12-week scan. I'd already said, look, I've already been for a scan anyway because I was too nervous to sit and wait. And she said, I can see baby, she said, but unfortunately I'm having to tell you now that the baby's heart has stopped. She said, I'm so sorry, but you're going to have to contact your local hospital and get them to do a scan. I went in the next day to the early pregnancy unit and I was scanned, and they said, okay, we can detect baby, but we can't detect a heartbeat. Obviously this is classed as miscarriage, because I haven't got any physical symptoms. So she said, unfortunately, you're going to have to come back in 2 weeks' time to get re-scanned. That's our guidelines, our protocol, that we have to re-scan you in 2 weeks. And I said, well, hang on a minute. I said, I've been to 3 private scans now. I can show you the reports, I can show you the scans. So the only way I could see a way forward was to put a complaint in. And it was just basically stating that I wasn't happy with being told to go home and wait another 2 weeks. This is agonising. Little did I know then I was to have a phone call a couple of hours later from the head of gynae. So within an hour or so of that phone call, I got called back, please come and see us for a rescan. Again, that the baby's heart had stopped. It just felt like a triple kick in the teeth, to be honest, to be told that for a 3rd time, although I knew. And then you get told what your options are. There was an option of D&E. So I was like, it went away, thought about it, and I thought, okay, just take the medical route. Let me have control of this. I started bleeding at home. I didn't have anybody with me. I had to drive myself to the hospital by myself. And I was greeted by 2 nurses in the ward and just fell to pieces. 4 hours had passed and the nurse came and she said, I'm so sorry to tell you this, but you are losing way too much blood. We are now looking at a D&C. Obviously I panicked and she said, but we have to do this to prevent any more loss, which is going to put you in danger. Had I been told a little bit different, that you could potentially end up in D&C, I think I may have gone straight in for a D&C. So I got home to an empty house. We had named the baby AJ because I thought, well, it gives some identification. We were given by the hospital a little bereavement box. That was a lovely touch. It's not something that I'd had with Scarlett. Telling me that they don't accept these private scans as proof. I did it because I needed reassurance of the traumas I've been through in the past. Is there no way of making sure that there's a database out there that has these accredited private clinics on the database that you can check? Having a health visitor knock the door, GP phone up or somebody just to check in that we were okay, that I was doing okay, that I was still able to look after my girls okay. Every heartbeat matters, no matter how small that heartbeat is. It doesn't matter that the baby's under 20 weeks. Acknowledgement that my baby mattered and my baby existed, because it feels like sometimes that isn't the case.
Thank you very much, Rachel, for having the bravery and honesty to tell us your story. Are there any questions? Well, how has it improved? What did we do as a consequence?
So, you need to go on to
There's a couple of slides.
couple of
what we'd like
slides
to
of
bring
just
down.
what we,
Okay, thank you.
So Rachel's, the first thing really that Rachel's experience highlights is that the bond with the baby is so strong from the moment of a positive pregnancy test. And that, you know, the minute we find out we're pregnant, and that's for the man and the woman, we imagine our life with that baby. And it doesn't matter how little they are. That's the experience that all couples that come to us tell us. The next thing that we kind of brought out was that previous pregnancy loss often leads to anxiety in future pregnancies. And for Rachel, that meant that she wanted to book an early scan. She wanted to have reassurance that her baby was going to be all right in this pregnancy. And that was something that currently we're not able to offer in the health board. So people are going outside of the health board to book private scans. The next thing really that came across was that the management of miscarriage needs clear communication, and the women want to have an informed choice in that management. So, for example, the guideline at the moment is that if we do, we need 2 scans in the health board to make that diagnosis. And I think for Rachel, it's really difficult that she'd had 3 private scans that we weren't acknowledging, and we weren't actually able to have that conversation with her to move outside of our guideline and do something different. That was what she wanted. Also that pregnancy management is not always straightforward, that sometimes women will choose one management that actually leads on to further treatments and further management. Our bodies don't always respond in the way that we're expecting them to respond. The next thing really was that grieving and pregnancy loss can be complicated by a traumatic and prolonged experience, which sometimes women are going through weeks of treatment. It's not like a come in today and it's all over. It often goes on, it's prolonged for a few weeks. And they're often waiting to come in for a number of days, if not longer at times, and which is where the dedicated bed does come into things. And the most important thing of all is I think women wanted to know that their baby mattered, and that we acknowledge that they matter. So some of the, let me change the slide again. Some of the immediate improvements that we made after speaking to Rachel, we immediately initiated a 3-week follow-up call for women that had experienced miscarriage. So now every woman, when she comes into early pregnancy or emergency gynae, we know they've experienced a miscarriage. We arrange to call them in 3 weeks' time. It's only a little call, but it's that welfare check really. Are you doing okay? Is there anything you need? Do you need signposting to any more support or help? And that has been so positively received. Women love it. They really appreciate that call. we acknowledge that communication and acknowledging loss it needs to be included in every training that we do. So whatever gynae skills or training we do, we always make sure that there's a part of that. So if we're doing skills and drills, for example, we will make sure that the communication aspect is added in, so that we're treating women empathically and that we are communicating their choices. The early pregnancy unit, we've changed the staffing around a bit to make sure that there's experienced staff in there all the time, so that it's consistent. And we're still working on that for emergency gynae. We've sent staff on stage and time training and counselling training, and to try and improve communication skills within the unit. We've devised a written information pack, which all women get given to back up anything that we're telling them verbally. It's quite a nice little design, and you know, it's nice to receive rather than something that was just a photocopied leaflet before. And then the information pack also signposts to relevant charities and organisations for ongoing support. We acknowledge that we do rely heavily on the voluntary sector, such as the Miscarriage Association, Beresford Centre, to provide ongoing support. And then some of the service improvements that we've made, we've worked alongside Jenny's been so supportive, as is Leanne, and Tanya Strange, to get a dedicated bed on A3, which we've named the Butterfly Room. So that bed is protected and does allow us to facilitate admissions in a more timely manner, so that whereas in the past we were kind of like waiting until 4 o'clock in the afternoon, now we can bring patients into that bed as and when it's available. We've also just recently turned a store cupboard actually into a little counselling room, which we call Perch. And that's just to give us an extra space really to sit with people when they're upset and to give them bad news and talk to them. The nurses on the ward are currently raising funds to decorate and do all sorts of things in there. And actually they've done so much this year, they've received some awards within the health board for the work. In order to validate the baby and acknowledge the loss, we always add memory boxes, but we've gone a little bit further and designed little bags. A little thing on there says "Carry for a moment, live for a lifetime." I gave a couple of these out yesterday in emergency gynae, and they're usually quite tearful, but they're very well received. And we've got Certificate of Life, which currently in England, any woman that has a miscarriage will have a certificate, pregnancy certificate, but it's not carried through in Wales. So we've got kind of informal ones, again, provided by charities. These little boxes, actually it's like a tiny little coffin, which sounds awful, but it's so much nicer when women want to take their babies home and bury them, that we actually give them their baby in the little box. And we've got various sizes. Some of our babies are much bigger. We work with medical photography now as well, so that we have professional style photos for mums to remember. We've got a memory tree on the ward. We've got partner packs, sibling packs. There's all sorts of things going on really in order to acknowledge that baby and that loss. So moving forward, we hope to just raise awareness by sharing Rachel's story. I think, you know, it does bring out how emotional this experience is, and that we can't disconnect that emotion from the care that we provide. We often, as medical nursing people, will treat a procedure as a clinical procedure, whereas actually when you experience a miscarriage, it's not clinical at all, and we can't separate the two. Rachel's happy to participate in any people participation panels for pregnancy loss, to provide the patient's view. We're in the process of securing a bereavement garden at the Grange. That we're just waiting. I think the building company that's doing work in ED has agreed to do the groundwork for us free of charge as part of their charitable donation, and the staff on the ward have already raised thousands of pounds to decorate the garden and to put plants and benches and all sorts of things in there once it's in place, but we're just waiting on that. They're working with the hospital chaplains to provide more multi-faith services and things as a memorial for babies. And they hope to secure a dedicated bereavement nurse at some point in the future. And also just the national pregnancy pathways, really. We participate in those pathways and adjusting our guidelines and protocols to suit. I think the biggest thing really is that we don't want women to have to complain in order to be heard. We want to be listening and trying to work with them really to improve their experience and improve our service.
Thank you. That was very, very helpful.
Incredible. Thank you. Thank you very much. Can I pick up the issue of private scan?
Yeah.
Because obviously a scan is a scan, whether it's private or not. Can you just talk us through the issue of why it wasn't accepted?
At the moment, the private scans are not accredited with anybody, so HIW don't, they don't have a database or anything really to say that that scan is kosher. So you can literally, my daughter bought a pram and had a free scan in the pram shop. So there's no accreditation for the training of that person that's doing the scan. We don't get a report or anything, although sometimes we can. So it does vary. And then there are places that people can go for private scans that are perfectly credible. But it's kind of hit and miss. So currently the guideline at the hospital is that we would expect 2 scans so that we could see the difference. Because you could, in a very early scan, you might not be developed enough to call it, not an ongoing pregnancy, if that makes sense. So currently, that's what our guideline says. But I think for Rachel, she was happy that her scans were credible. She'd had 3. And when she came in, we kind of like stuck rigidly to that guideline rather than listening and, accepting that she can make an informed choice.
I just step in there and just say that the scan that I went to, I did do my research. I didn't just walk to any high street scan place. I found one that was reputable, which was next door to a health care place in Hereford. They scanned me once, they couldn't really see much. They scanned me again, offered me a free scan, because also you have to pay for these private scans. So when she offered me the free scan to come back in 2 weeks, she said that she could possibly see 2, but she wasn't sure. So she offered me another one. That's why I ended up having 3 scans with the private clinic. But also on the 3rd scan, that's when she said, although we detected a heartbeat last time, I can't detect a heartbeat now. So you'll have to now go to your NHS hospital. Obviously, that's when I went through to the Grange. But unfortunately, they wouldn't accredit those scans, even though I'd had reports given to me, scan photos given to me, and a video given to me. It obviously, just because of the protocols and guidelines from the NHS, they wouldn't accredit those. So obviously, being given a scan in at that point, to be told, yes, your baby, we can't detect a heartbeat at this time, but unfortunately, you are going to have to come back in 2 weeks and get rescanned. I just knew in my mind then, I was like, right, that's 4 scans now. I knew at that point that the baby wasn't viable. So I was like, right, but I want to start treatment now, because if I wait another 2 weeks, that's agonising to go home, knowing full well that I've lost the baby, but not knowing what my body was going to do next, because it was a miscarriage. And I've got 2 children at home on my own. So I was like, if anything happens in that time, what do I do? So I thought, if I can get treatment as early as possible and kind of manage it as early as possible, then surely it'd be better for me. But like I said, under the guidelines, it just wasn't an option. And that's when I put the complaint in to say, this isn't good enough, something needs to be done. Hence why we're here.
Can I ask, so what are we doing about information to women regarding the scans then? Because obviously, if you didn't know until you got to the hospital about the accreditation, so would that have made a difference?
It would have made a huge difference. And this is one of my arguments I put across, was there needs to be that communication out there for women to know that private scans aren't a validation when you go through to the NHS, and they won't admit them, they may dismiss them. And that's really, really important for women to understand that can happen.
And is that on the action list of things that we're doing?
So yeah, we're going to pick that up in terms of how we address that. It's probably a conversation with Andy.
Yeah, it's a difficult one, Paul. Just for clarity, the 2 scans within the NHS are needed for corroboration due to legal challenge previously. We then clearly make interventions, be that in tablet form or surgical form, to obviously address the unfortunate.
We did at a local level, because an individual will notice particularly something that's gone on in their team or their, you know, in their directorate or their division, may notice something that goes on organisationally. So it's trying to have that.
We need to shout about what we, because we do a lot, you know, it's not as if we just sit on it, but we just need to show you a little bit of people and culture.
Absolutely agree, you know, that's so important.
Neil and then
yeah, I just come back to the point, you know, that when we were doing the well-being survey, and one of the key things is that there is definitely staff or the survey fatigue, you know, the sheer number and different bodies. And the challenge is that each body is trying to look at these things from a different perspective and trying to extract a different set of data. And that creates a huge challenge, because the trade unions, for example, or the in the All Wales data, that is slightly different to what we want to get from our staff. And again, we want to tailor it to our needs, and that creates a huge problem. And I think we need to have initiatives, as Sarah was saying, about having drop-in sessions or having people outside the canteen, or, you know, say when they have team meetings, to engage people a bit better and get more mileage out of it. And going back to your question of how many questions, that is, again, the more you get, the more questions you have, the better data you have. But it's a catch-22, and it's a very fine balance, you know, that if you don't have enough questions, then the survey becomes meaningless. So
I think it's interesting. I mean, you mentioned, Anne, about the percentage uptake in England. Is it to know or to find out what the number of questions are?
yeah, we've asked. Oh, there are more questions actually.
But there are fewer surveys.
Well, I don't know about the future service, but there's certainly more questions than the
I
staff.
think somebody at somewhere strategically should look at mapping out what surveys there are across the system and saying, right, well, can we prioritise these? Not so much they shouldn't happen, but they could say, we'll do this in spring, this in summer, this in autumn, this in winter. So people have got a much more clear, and particularly with the trade unions, professional associations, they can then advise them, their members, about when to fill them in.
and I think maybe if we have on the intranet or somewhere a page where those responses or those issues that are raised in the surveys are, you know, the address points, that will probably improve engagement as well, because
It's
people,
already.
yeah.
So I think it's about how we share that.
Yes.
Use yourself with Vec and other staff forums to share that.
Yeah,
I
good
think
idea.
we can work together really positively on that.
Thank you. Last comment, Penny?
Yeah, it's about the feedback really, and going away from digital. Dare I say that? But and I'm going to harp on about it again. When we were going around the patients, the wards, we saw the use of the boards in the wards to encourage, to show their successes and their accomplishments and everything. And a fantastic thing. I want, I keep on about it, and I see Karen's online, a board placed on a wall, a large board as we come into the Grange, for instance, but every hospital, stating, you know, showing what awards have been won, and et cetera, et cetera. And on that board could be, you said, we did. Just a couple of highlights, not detailed, but, you know, look what we can accomplish together. So people look up and think, oh yeah, and perhaps fill in the survey next time. We don't say enough about what we can do, and we don't empower people enough. And I think we rely too much on digital responses. So can we use a combination and use communications to help, you know, put it up on the board? So that's my bit. Sorry. Yeah.
Thank you. So we're happy with the plan?
Yeah.
And thank you very much for all your hard work in leading this, because it's
Yeah.
Thank
fit
you
for the
Thank you
future.
to all the teams that have contributed.
Thank you. Can we move on to the winter plan, Hannah, please?
Yeah, thank you, Chair. So the purpose of this paper is just to update
colleagues on and build on previous updates that have come to board with respect to winter planning. And it's just important to note that this is it's never kind of done or finished. We continue to iterate as more information sort of emerges. I just want to call out a few key points from the paper that have been new information since the paper. So the paper does refer to and we'll know from a previous winter plan reports that we do rely on national modelling to give us some insight and intelligence for how the winter period is going to look. So Public Health Wales produce some modelling that indicates both the timing of and the height of surges of infections, and then we use that information to combine with our activity information to get a sense of where those peaks are going to be in, and sense check our plans are going to match and manage that expected demand. We haven't had that from Public Health Wales yet, so clearly we can't finalise our plans fully, and we are expecting it by the end of September. Tracy and I having a quick catch up this morning to try and work out if anybody had any intelligence, but all I know is that we are due to still have it at least by the end of next week, if not before. Notwithstanding that, we have in our approach for this year try to, rather than do lots of actions across a lot of areas, trying to really hone it in terms of lessons from last year. So just the key areas we're going to focus on in the context of winter is vaccinations, and we'll come back to that in a minute. The management and proactive management of high-risk patients in the community, targeting priority pathways, so falls, for example. And critically as well, we've touched on it in a few of the updates already, there's a suite of actions and process and pathway improvements on the back of the Task Force 45 and Your Next Patient that identify opportunities to improve and put some groundwork in before winter. And then next is the additional bed capacity. Whilst we haven't yet got the clarity of when those surges are coming, we know they're coming, and notwithstanding other actions, we are developing the granular plans for surge bed capacity. And then last but by no means least is the work with our partners, and especially in the RPB space, around supporting discharge to help that flow throughout the winter period. So just a few points on a couple of those, not on all of them. On vaccination, we've received, we've already started in this space, and Tracy may be able to come in and talk to it where we are. We know we weren't where we wanted to be last year, either on staff or on community take-up rates, and we absolutely felt the effect of that in terms of sickness and impact in demand. So we've already started the work, but we received correspondence yesterday from Welsh Government around some expectations and communication for professionals and others in the vaccination space. And we have a very detailed kind of underpinning delivery plan around that. As I said, we're already into that and showing good progress against numbers, and especially compared to last year. Secondly, just to update on the RPB, there's met since these papers were finalised, and the RPB supported investment into a number of discharge supported schemes, such as the equipment scheme. GWICIS is the acronym we use for that. So around 217,000 to go into support that, and in terms of supporting discharge for patients who require enhanced care and before going into care homes. So a big investment on that for a 6-week period. Just to note, additional to that, local authority colleagues have received additional money to support 7-day working for social care. And then finally is the work ongoing to do those granular plans around surging bed capacity in our hospital facility. So that's underway. From a governance perspective, we will be tracking, as we did last year, through weekly exec meetings, both the vaccination uptakes to be seeing how we are on our plans and if we're on track, and also tracking against the modelling that we do when we have that. We will have the cross-divisional meeting, the AMS cross-divisional meeting, to track on some of the other actions that we own and have identified. There are some risks in the plans to date. We are doing this work in parallel with teams working on the Your Next Patient initiative that we've talked about, and which is, an ask we've got to acknowledge in terms of operational clinical teams. I've touched on, it's at risk. We haven't received the modelling yet, but are expecting that. And clearly workforce and our ability to retain staff during the winter period and provide staff to support capacity is a risk. Funding is an issue that I've addressed some of where the RIF monies can help. We have to recognise that any additional costs associated with bed capacity aren't yet in our financial position that we talked about in a recent development session, so we'll have to find opportunities to mitigate any costs there. And one risk and or opportunity, depending on which lens you're looking down, is we haven't yet had any confirmation if there are going to be any Welsh Government initiatives and or money with that. Like last year we had the 50-day challenge, so that's yet to be confirmed. So next steps, the review the modelling once we receive that, those detailed capacity plans, and commence that tracking of the progress against some of those measurables. So happy to take any questions.
Thank you, Hannah. I note from the circular that came out from the Deputy Chief Executive of NHS Wales, there's a vast array of projects against which we will be monitored, measured, held to account, none of which seem to have any resource attached to them at the moment.
Is this the self-assessment that went through the RPB?
Well, it's called Planning Together for Winter.
Oh, yeah.
Expectations, key actions, and there's all this lot.
Yeah. So that's, yeah, we haven't yet. We've had lots of sort of steer or instruction. There's a few letters on winter, so I was just clarifying which one. But as of yet, we haven't had it confirmed unless it's come to any other peer groups or other mechanisms that there will or that there won't be any additional funding to support winter. History will tell us there are opportunities. However, that's not yet been confirmed. Or
because the outcomes that we want, there are 2, 3, 4 very closely typed pages of the outcomes. And who is going to be responsible for collating all the information? Because is it going to be left to the RPB, do you know? Because it encompasses us, local authorities.
Yeah, the reporting burden is
with the RPB.
Yeah, of which we'll be using the team we host on behalf of the RPB to support. But as with some other areas, you know, of our business, not just winter planning, the reporting burden is quite heavy.
Thank you.
Annie?
Yes, I just, with Welsh Government funding and in local authority, we have the same thing. Any funding we promise is always left to very last minute when it's almost impossible to use correctly. But however, was the 50-day challenge seen as a success last year? Was it viewed as a success by Welsh Government? And are they likely to come forward with something? I would have thought, you know, I'm going to use Paul's phrase here, as there's an election in May, they may be, you know, slightly more susceptible to extra funding. But if the 50-day challenge was seen as success, then surely, you know, more will be forthcoming.
Yeah, so I got a couple of responses on that. I'm sure Jenny, who led that for us, will come in as well. So there will be things we did within that were successful and had an impact, and some things that didn't. If you look just at some of the key metrics that the 50-day challenge was very explicit about what it was trying to do in terms of reduction in the actual numbers of fabric delays and reduction in the number of days delayed. We achieved that. We did really well. This region did really well on that. The targets that were set by the percentages, I can't off the top of my head remember what they were, but we achieved those. And it did indeed go on beyond 50 days, didn't it? And now it's hard because that, you know, action and cause is sometimes really hard in complex systems, and lots of initiatives trying to all support an improvement in the same measure. So directly attributing is you know, I think frankly is hard. But you know, we did see, didn't we, Jenny, a significant improvement that we have sustained beyond the 50-day challenge and beyond the investment of the 50-day challenge. Interestingly, I don't know if you wanted to.
I just ask one other thing. The GPs. you know, is working extra time and surgery. So that seemed to be a great success.
Yeah.
Are they involved in all the meetings to do with winter planning? Are they actually at the, you know, at the table?
Yes, so so not all of them, because there's many of them, but the NCN leads.
Represent.
Yeah, the NCN leads absolutely, you know, and sort of led by the division, primary and community division. So yeah, but it is, you know, there is in terms of like being able to do more, there is a below the line list of opportunities that we in the health board and the partners have identified where were there to be more investment, either through slippage in RPP monies and or money coming through from Welsh Government that we could mobilise, and some of those are in the space of the GPs in terms of MDTs, but some of it, to be clear as well, is they've embedded some of the actions taken from last year in terms of the MDT approach to looking after those populations at risk. So we have taken forward and mainstreamed, not at the scale we probably need to yet, but mainstreamed those initiatives that worked last year.
Thank you.
Thank you. Paul?
One of the issues for the winter plan is, of course, we've got try and got as many beds available as possible. When I visited Neville Hall recently with Nicola on walkabout, we had the opportunity of talking to, I think it was occupational health, was it rehabilitation? And what was interesting there was the inconsistency across the different areas with regards to assessments, and that I'm raising whether or not there's any advancement on the trusted assessor model. Because in terms of the regional partnership board, this is I think that the Welsh Government have indicated this is something that should happen. I know there's a reluctance amongst certain areas, but at the end of the day, what is important is what's best for the patient. And if we've got a winter plan that is predicated on us getting as many people who are well out of the hospital and home and safe, then that could be certainly helped considerably by the trusted assessor. I wondered what the movement was on the latest position statement is on trusted assessors, and whether we need to write to the Welsh Government just to say, could they, you know, move this on further, because we're having some difficulty.
Agreed. Do you want to say that?
So there, in fact, through the Handover 45 work, trusted assessor has come up. But I don't think it's Welsh Government that need to action trusted assessor. It will be local systems, because the issue is the integration between health and social care in terms of the ability to enact that model. There is going to be a piece of work done nationally to develop a memorandum of understanding that it is expected that local systems will adopt, which will describe the trusted assessor model. However, through some of the Handover 45 work, I think what's been interesting is the level of integration with health and social care varies very much across the piece. Swansea have done quite an interesting piece of work around working more collaboratively with an MOU that covers more than trusted assessor. So it covers much more that whole piece around how do you work in an integrated way, particularly across the urgent and emergency care pathway. So I think almost the discussions we need to have are locally supported by the national position. But I do think we need to go a bit wider than trusted assessor, because I think there are multiple opportunities to do things more efficiently and effectively with the local authorities. I think it will be helped by the investment they've had. It will be helped by the review of Home First that Hannah's referred to, because that will free some resource to enable us to look differently at those local pathways. And we do need to really start to address, we've started seeing a creep up in delays in assessment by social care. So we need to be tackling that now ahead of winter. And I think there's an opportunity to have a slightly different conversation, which is where Swansea have got to really in terms of their way of working. But may I on the 50-day challenge?
I would agree with Jenny about looking at this more comprehensively. But we do have to make progress, because one of the requirements from the circular is to actually deliver the trusted assessor model. So this very minimum is we've got to deliver something that's actually better and more effective for the patients and the clients. If we're not going to do the trusted assessor model, so that's what we're working on.
Absolutely, and I think that's where we
So time frames, as you said about memorandum of.
I've just literally had an email last night from Welsh Government about it, so they'll be progressing that, I would imagine, at pace, because they are progressing some of the 45, get confused about 45 and 50s, the handover 45 work, because the handover 45 work isn't just about the front door, it's about non-conveyance and pre-hospital, and it's about the back door as well. So I think they will pick it up through that route.
Could I ask, could we have this as a report or something for the next meeting, so we can progress this? I think we can. I thought the minister was Minister of Health and Social Care.
Yes.
So
and children. This will form a core anyway within the board briefing sessions that we have. You know, we'll get a continuous update because so much effort is being expended in tackling this really difficult problem for the benefit of the patients, and a lot of work from all the agencies is going into learning from last year and what really worked well, maintaining good relationships and actually trying to do something a little more effective.
Well, actually, it's really good best practice, I think.
There is some
talking to some
very good
members of staff. They were taught, and I was thinking, if that could be replicated, that would make such a big difference.
Just on, so we do have trusted assessor in places, I have to say that.
Yeah.
What we don't have is universal.
Right.
So we have models, we don't have it universal. That's what we need to work on. That's where we need a different conversation, I think, with, you know, probably at director level and chief exec level in the local authorities. On the 50-day challenge, I think it is seen as a success nationally.
Yeah.
If you look at the metrics that are produced nationally, actually they would indicate a move across the 10 high impact actions in the right direction.
Right.
I think some of the work now is around how that's embedded and there's not a move back. And I do think probably we were seen as one of the regions that made the biggest impact because of our impact on particularly pathway care delays. So I think that was really positive from our perspective, and that was recognised.
Thank you. Thank you, Helen.
Any further questions on winter? Loads of questions remaining. We don't know the answers to. I think that we've just got to ensure that the goodness isn't lost and is promoted, because we are going to have a difficult winter. Yeah, say the least. Want to ask something?
Well, I think it might be covered too much. Probably going to state the bleeding obvious here at the moment, because the plan as it's coming along is quite comprehensive, obviously, but we're totally or highly dependent on finance, staffing, partnership working, all of the things that are under huge pressure already. You know, we've got in there that Southern Hemisphere looks as if it's going to be a bad one coming. All the pressures coming up in the US and online and all the rest of it against vaccination. Even paracetamol is having a hammering at the moment. Yeah. Everything is pointing towards us there's a bad one coming, and always seems to be our only, not our response, but the only way we can cope with it is we'll all have to roll our sleeves up and pitch in. There doesn't seem to be a plan B, as it were, or a contingency in there as to, well, if we are hit by a bad one, but all we can do is just, we'll work harder kind of thing. Is it?
Yeah.
Fair or unfair?
Well, yeah, so we'll have a plan. The plan B is, and we'll be, because
we'll have to work harder.
Yeah.
There's not really anything we can bring in to help.
Well, the important thing is that we try to, through tracking, when we have the national, check it ourselves with the international, because that was something we kind of maybe didn't do as assertively as you know, when we received the national, the modelling, and combine it with our own intelligence on numbers. Is that then very real time and weekly then tracking to see if the plans are holding up? Because as you move through, if they're not, we have to make, and we do it collectively and when appropriate with you, but operational decisions of redirecting capacity, whether that's people, space, you know, flexing things, in line with our normal sort of escalation arrangements.
Do you mind if I just come in there? Part of the reason that we wanted to go with Your Next Patient now is to try and get some headspace ahead of winter, knowing that it was coming. There's a perfect alignment from a timing perspective around a number of different things. But what we are experiencing through Your Next Patient, I think, is pretty significant opportunities if we focus our efforts and are almost forensic in sort of delivery of some of those things and the sorts of benefits that we're seeing. And part of the reason we've had such a prioritised and focused whole system response, I think, is picking out those things that will make a material difference to get us there. So I think, you know, we are only, you know, just into the third week at the moment, but there are lots of things, you know, there's a long running list of areas of opportunity for us that is very targeted and focused and evidence and data driven, so we know what will have a material impact. And then I think there's a collective decision for us about the things that we want to continue pushing up after this more intense period to try and give us that headroom, knowing that's coming as well.
Tracy?
Yeah, just on the vaccination piece, as you know, vaccination started really late last year, and I think that was one of the challenges in terms of getting our staff vaccinated. They just didn't have the headroom to find the time to get vaccinated, so we have gone early this year. So the national programme doesn't start till the 1st of October. We're about 3 weeks into our staff vaccination programme, and we've done about 25% of last year's staff total already. So it is proving that actually by getting there before the staff are swamped by winter pressures, people are taking up. So we are going to continue to drive and push that and hopefully get better coverage, because that will protect our workforce, which will obviously help us with workforce capacity. I have put a call in to see whether we can get the modelling in for today, and it's not available. It's due out next week. But once we've got the national, the UK and the Welsh data, we will do that analysis and give us a picture in terms of what it will be.
Good, thank you. Anna? Yeah, just so on the vaccination, so Tracy led a really good session with the senior leadership group, which is execs and the triumvirate leads for divisions last Friday, and I was in a group that was looking at vaccinations and what we can do, and so and it was great to see some of it, the ideas coming through already in train, but there were some other ideas as well, and some of the which I think sort of links. We talk a lot about strategy and how now we've got the people plan, which is one of those keys to that. But we talked a lot as part of the strategy about that compact with the public, you know, our part, your part. Well, this is the first bit of that. So how can we think about our comms in terms of using those networks we established through that work, those community leaders, those community groups? And we came to talk to you about the strategy. This is our first kind of like, you know, ask of you, or, you know, we'll think about the communication around that. But use that and use those networks and those engaged community leaders and or community groups to say, you know, our first kind of ask in this compact is about vaccinations, and this is information, and this is where you can get your vaccination, and this is, you know, so it's trying to keep, you know, bring it back and use that valuable kind of engagement we got from that process to support this agenda.
Just on that point, Anna, if I may, so we're holding a vaccination summit, which is a community conversation in October to do exactly that, and some of that will be to a challenge what is from the work that we've done with communities over the summer around this emerging, what is emerging as a myth around vaccination hesitancy, is being almost dispelled by some of the targeted work we've done around certainly teenage vaccinations, which has been a lack of information, a lack of awareness that these vaccinations are available and how to access them. And we've also had challenge around getting e-consent. You know, when we're vaccinating children on school sites, we do need parental consent, as is right and proper. And there is a look now and conversations happening in terms of how we can get child consent that lasts a school career rather than needing consent each time, where parents can opt out at any point that they change their minds, but we're not having to go back out, and therefore because we haven't got consent, we're not vaccinating there isn't parental awareness. So there is something about the information loop, so that's also going to be tested at the summit in October, just to try and see how we can get better information, because when we did the case find and identified those parents, we were able to get another 200 young people through their vaccinations that we hadn't had consent for previously. So it was just lack of information. So there was something about trying to dispel some of the misinformation out there, not only on vaccinations, but all treatments and medicines. Go out with an evidence base, not give any time to the nonsense, but just keep going out with an evidence base and a truth about the vaccinations that are out there to support and protect our populations.
Good. I'd just like to say that will please the parents as well, won't it? But also the school staff, because, you know, it's a tremendous burden having to get consent all the time. So that is an excellent idea. In fact, it's so excellent. You think, why hasn't it been done before? It's a bit like, like organ films. So well done. Got what I was going to say now about the other. Oh, I know. Just a point. It's just a comment. Of course, a partnership with all this is with local authorities, and they have their own problems at the moment, big time. So, you know, you've got an added strain this year that is probably a bit more pressure than last year.
Vivek?
Just a quick one is that, you know, on this plan, the biggest challenge I think is that once a patient comes into the hospital, it is always a losing battle trying to get them out. And if we can strengthen our services or our links with the community team and primary care to see how we can manage more in community and reduce the workload within, you know, it's a simple thing to say, and it's a huge challenge. But I think if we invest some resources there, I think that the value for money would be far more.
Yeah, absolutely. And that's where the RIF slippage is targeted at those opportunities.
Okay, well, we recognise the consequences and the issues that aren't yet clear and cannot be clear, but I think that, you know, we've got to commend the fact that there is help planning going on, and we've learnt from what we did last year with our colleagues, and we will note the content in which we are trying to operate this system. And we'll keep up to this. Thank you. 5.3 Llantrisant Health Park.
Okay, thank you, Chair. There's a few, there's 2 items under the regional planning section now. I'll take the first and then Ronnie will take from the regional committee. So in terms of the Llantrisant Health Park, LHP, as we call it, OBC, so outline business case, lots of acronyms. It's brought to us today as a board to note the OBC. Colleagues will remember that back in March we approved a vision document for LHP that set out the opportunity and the emerging thinking and the status in terms of the ownership of the site and the progress that had been made to date on working through service models and opportunities. So this OBC is the first to come forward in a suite of OBCs we can expect. It is a CTM OBC, so it's not for us to approve today. So it's CTM, Cwmtaf Morgannwg Health Board, who are asking and seeking investment and approval from their board and from Welsh Government. But there is clearly a regional dimension, hence it's important that we note the business case today and a request to endorse the element that does and will affect us in terms of endoscopy capacity. So very, very briefly, the OBC, the business case covers, focuses on the requirements for the community diagnostic hub element of Llantrisant Health Park, and remembering that Llantrisant Health Park will have a community diagnostic element, so radiology, so scans and endoscopies, as well as a theatre and a surgical element. That surgical and theatre element, OBCs are to come and to be developed. So the focus of this is the community diagnostic hub element, plus some investment into enabling works, as we call it, for those future cases. The plan is for those radiology. The radiology provision will support Cwmtaf Morgannwg only, but from an endoscopy perspective, as per that vision document we agreed, is for endoscopy suites that service CTM Cwmtaf Morgannwg capacity and some capacity for the region, so for ourselves and for Cardiff and Vale. In addition to that is the allowance in the capacity planning for an endoscopy training facility, which HEIW are sort of leading in terms of the model, but require the space to run that, which will absolutely be a benefit to the region and more widely because endoscopy and workforce can be a challenge at times. So we've done detailed assessment within the organisation in terms of our requirements for endoscopy capacity. We know we've got some great facilities already in the region and recently in the Health Board, and relatively recently opened the Royal Gwent new endoscopy facility that is not yet at full optimisation in terms of resources. So we could run that 7 days a week, 2 sessions a day. At the moment, we know we're not at that based on the business case investment. So our assumption is that we first max out our existing capacity, drive efficiencies, and then when it comes to 28-29, we will have a capacity gap due to the demand that is growing, screening, diagnostics, cancer pathways, etc. So our assessment will be from 2028-29, we'll have a gap of half theatre that we will commission and commission that activity from the new facility in LHP. There's still further work to do as the business case progresses in understanding the costs and price associated with that due to the use of a managed service contract to provide that. So that will be something we need to continuously bring back to the board and test on a value for money basis. So I'll pause there, just noting that it's for us as a board to note rather than approve. Note the work done on the endoscopy requirements from a date in the future, and endorse a commitment at this point that from that date in the future we will look to LHP to provide that, subject to it stacking up on a value for money basis.
I think the value for money issue is extremely important in this discussion.
What about anything, Nicola? I missed something else in it.
No, I don't think so. I think it's kind of good to see it kind of developing a bit more clarity around. I think it's been useful that we've kind of divided the overall plan for Llanda's Health Park into different components, because we've got a greater interest in some more than others. So I think this is helpful, and so yeah, I think our kind of consistent theme is, you know, there's lots of opportunities through a regional kind of facility, but for us, we absolutely need to go through the same due diligence we would put on anything that we would choose to do locally. So that's kind of the consistent theme, is making sure that we can demonstrate that in any cases, and that it fits in with our kind of broader strategy and the needs of our population. So yeah, thank you.
Rob and then Paul.
Yeah, just because I'm not sure it's drawn out very clear in the case, is that from a health board perspective, we're very clear this is additionality, and at this point in time we do not have a funding source for the proposed £500,000 cost of revenue under the estimates now. So just so the board's aware of that, we'll be looking for Welsh Government ultimately to help us to support that.
Yeah.
Thank you. Paul?
Yeah, well, that was my sort of, when I'm looking at the figures, I think it's page 224. 224. Talking about Cwmtar 4.8 million, this is recurring revenue, 4.8, Cardiff and Vale 2.2, that's 7 million in total, and then ours was 0.5 million. Now, as part of our visit the other week to Neville Hall, we went to the endoscopy unit and heard some really exciting stuff going on there and in the Gwent. And I thought, to be perfectly honest with you, my view would be, if you're looking at the patients in Gwent, that 0.5 million investment in endoscopy would be far better spent in our locality for patient travelling, etc., rather than being invested in something which is, you know, a £110 million cost of the park. And you're thinking at the time when this, you know, is this something that obviously they're making a decision about, that's separate to us, but in terms of our involvement and input, 0.5 million of the 7 is a very small part of it, and it's not something we've got as part of our budget. And I've got real reservations about whether where the money's coming from and whether or not we could be associate members or something rather than going in and signing the papers and being part of the governance team when in fact, ultimately, we have capacity within our existing organisation.
Yeah, so just on that, just to be clear, so from working back from what Rob said as well, in the overarching kind of regional plan on endoscopy and in our internal assessment of what we would and could require is a desire to, as you said, and an assumption that we maximise our own capacity first, for all the reasons you've said, and we haven't, and as well as the money for LHP, we haven't got that identified yet either. So from a regional plan perspective, our preference is, as you said, we max our efficiency opportunities and any domain expansion in terms of additional kind of theatre suites for endoscopy, but running those sessions, sort of sweating our existing assets. But we will still have what we know at the moment. The world of medicine changes rapidly, but what we know at the moment, notwithstanding that, there still will be a gap, and we've, not immaterial, but a gap that we have at this stage said we will look to close that gap through LHP, because we will, at that point, we need to be focused on maximising our own internal opportunities to keep patients closer to home, to get maximum benefit through the big capital investment we've already made, especially in the Royal Gwent. So that is because of those reasons you said, that is part of the sort of the strategy reach.
That's the reason why we've got such a low proportion in year, is because we have maxed out our existing facilities first, and then this is the shortfall.
But it's got to be value for money against all the options that would be available to us at that time.
So the question I suppose I'm posing, which is, yes, I can see the Cardiff and Cwmtaf from Cardiff. They need that sooner the better. But why are we being asked to give a commitment for infrastructure and revenue costs when we haven't got them at the moment? Is it a position whereby one could say, well, you go ahead with the model, and can we come in at a later point rather than expecting to contribute?
That is what we've done.
Okay, so I'm looking at the next stage is signing up to a regional governance model. And if that's the case, then one would say, well, we're not part of that because we're not going to be involved in funding it.
No, Paul, we cannot do that. We have been directed to have a regional partnership model.
Right.
So, and there are real advantages in having the regional partnership model, which have already been enacted, for example, in terms of vascular surgery and in terms of some of the stroke services.
Yeah.
We have already moved things around as a region to ensure that we get a better bang for our buck, basically, or better outcomes for the people. And the fact that we've got ophthalmology as well, in Neville Hall, that is part of the regional plan, and we are taking people from Cardiff and Cwmtaf into that. So this is part of the, we have to have an agreement on how we operate. This would have been a loose arrangement at the moment. The minister's taken the decision, directed us to form a committee.
Right.
It doesn't mean to say that we have to invest in absolutely everything that somebody else wants.
Right.
That is our opportunity. We will know when we get to it, from the paperwork associated with the partnership. It is for the health board to decide what they actually address.
That's helpful.
Is that right? Yes, right. We're all agreed that it's fine. Yeah, Rob.
Yeah, just to add to that, I think the language, I think, is something we need to be clear on. So the regional committee is bigger than LHP.
Yeah.
Even though it seems like the LHP is driving it, it's actually bigger. It's separate. So I think that's quite important for the board to be aware of, as you said, Dan. In terms of the financial commitment and the activity commitment, it is pretty minimal, but it's representative of the work we've done. And I think, as Hannah said, so on top of me saying we've said that oh, we will be saying Welsh Government, this is additional, we haven't got a funding source for it. We've actually got to find funding source for the element of work that we want to step up internally as well. So there's two steps here, just for that clarity.
Yeah. Ewan?
Yeah, I think it's important for us to be more on the inside than the outside of this stuff. I totally agree that we need to be seeing what's going on. And the one thing it does, and it's highlighted in the plans around the workforce arrangements for a lot of the site, and I would say the workforce pipeline, but the lack of a workforce pipeline at the moment, because that is going to impact us in the short term. If a lot of staff are being sucked into this one area, then it's going to impact the fact that we'll be able to max out what we've got. And how do we then make sure that that pipeline is in place so that we have got the workforce there to be able to staff one area and ourselves? That one, it does concern me around the short term bit.
Yes, that is with all of any kind of strategic and especially expansion additionality plan, workforce is the biggest challenge. Above money, I'd say, you know, we could have the money, but it's the workforce for the reasons you said. So the model being pursued, because we would be in a commissioner provider relationship on this element with CTM, that's the model being pursued for this bit. So the vision of workforce and the first that is being promoted through the OBC is it's not NHS, it's external it's, you know, managed service contract provision. And that is why the training academy element for endoscopy is so key to get the system into a better place where the pipeline is there. You know, there are challenges in a number of workforce professions associated with endoscopy. So the development of that academy is key to generating the pipeline. But you're right, there's not a lot,
isn't it? We're developing the academy now, then we're talking still 5 years or whatever.
There is still questions and work to be done on workforce for this bit of it and that pipeline, and there will be when we come to the other OBCs in future boards.
To me, they don't really address, you know, it's a risk, but it doesn't seem to be an answer to it. There's no plan B, a plan B, there isn't one.
Just to look at on the independent service provider, which is the model they go in, is making sure that the recruitment processes don't stabilise our workforce, which has been kind of recognised as a risk. And there's been some caveats, I think, put through the procurement process, but it's quite difficult to manage.
There's a scarce resource there that we're trying to, we're all fishing on the same pond.
Thank you. I was just going to say on the same point with you that workforce is going to be a big issue, and thank you for clarifying, Hannah, that it be an independent provider model. So I assume that there will be no workforce who's we won't be actually contributing physical workforce, both for, because the academy model that for the radiology side, they do get radiologists from all over. Contributing to that. So is this model completely different in terms of?
So we won't be contributing workforce to the endoscopy theatres, well, and obviously radiology, but to run that additional capacity. There is still work to be done on what the academy model even is, you know, learning from the radiology academy. But again, there would have to be, that's an additionality. We haven't committed and are not committing to servicing any of that through existing resources.
Challenge and another kind of ones really.
Again, we won't be directly contributing, but indirectly, if they're recruiting in one area, they could easily be taking our colleagues in there, wouldn't they? So indirectly, we would be contributing to it.
Well, as Nicholas said, they've built some safeguards, I guess, into the procurement spec for staff so that they're not able to. Yeah.
There's some protections there, I think, as part of the risks that we identify.
But I guess we wouldn't stop it. I mean, who happens to live in Swansea and works here, or lives in Llantrys and works here, for going, I want to go there, kind of thing. You could restrict trade in that kind of.
No.
So it is still a risk to us.
So I think we note this OBC is a Cumtaf Morgannwg plan and a case with some regional elements. So we've got to carefully word this. We have a commitment to commission a share of endoscopy in 27/8, subject to the value for money case, and subject also to the workload being equivalent to our most productive endoscopy suites, which it isn't at the moment in the plan. And basically that the endoscopy plan that we would endorse will be subject to those caveats and also subject to our receiving additional resource. You happy about that?
Well done.
Right, now the joint committee.
I think Ryan's going to take this one.
Okay, thanks, Anne. So as Anne has mentioned in his update, this joint committee is established in response to a Cabinet Secretary direction in April, and the purpose of which was clearly set out by the Cabinet Secretary in his letter and is summarised in the introduction of the terms of reference. The cover paper provided just summarises the scope and membership of the joint committee, with an update on the approach to regional planning, and sets out the intention for regional organisational development programme to support us move through as we embed this way of working. The terms of reference, I won't go through them in detail. They've been developed by myself and corporate directors of corporate governance in CTM and Cardiff and Vale, Alpha boards, and have been well engaged through chairs and CEOs and directors of planning for comments. So have been commented upon a number of times before they've arrived in front of you today. Appendix A to the terms of reference set out a scheme of delegation and reservation of powers, which provides an outline of what the joint committee can and can't do, and those aspects that are reserved for health boards and statutory bodies. And as Anne said, in essence, the boards will determine the priorities for the joint committee, and that will be the scope of that work programme as derived by boards. So here for agreement. I won't go through them in detail, but happy to pick up any questions. Thank you.
Any questions? No? It has been well thrashed through.
Yeah.
So we approved the establishment of the regional joint committee and adopt its terms of reference. Okay, thank you. Would you like a cup of coffee? Please.
Thank you.
I have to go for a
Interest.
Could we move on to item 5 for performance management and accountability framework, please? Gosh, Anna, you're doing a lot of work.
It's not, yeah, okay, so thanks, Chair. So I've previously reported to Board and Finance and Funds Committee. We've been undertaking a review of Performance Management Accountability Framework, the PMF as we call it. It was, the board approved it, it was at this September meeting 2 years ago actually. So we've been sort of running at this and implementing it. The intention was to review after a year. We did start the review probably just over kind of 16 months ago, being implementation. There's so you have a cover paper. I'm going to assume everyone's read through the cover paper. There's a report on some of the findings of the review, and then there's a refreshed framework for approval today. So just a few things to draw out. The review has incorporated a number of kind of elements and approaches. So we've had sessions with divisions, with executive, we've run a survey, we've drawn out themes from the discussion at F&P. The session was unfortunately cancelled, but we did send out the information and invite sort of feedback and opportunity for further comments. We've also reviewed other similar frameworks to pick up any sort of best practice lessons learned, and we've had an internal audit report on its application. So we've had quite a lot of feedback, insight and information that we tried to synthesise and to come up with some recommendations and an updated framework. I won't go through all the kind of like the detail that's in the information, but just to draw out some key areas that have been updated. So you colleagues will know that in the context of the framework, as well as setting out how we review and give oversight to performance through the meeting structures and the information, the framework also sets out the escalation component within the framework, and that probably has attracted the most kind of conversation and feedback, if I'm honest. We have, through the feedback, are proposing to expand the domains in terms of the areas for consideration and therefore escalation. So we now have leadership and governance as a domain, whereas previously, just remind us, we had finance, operational delivery and quality. So the proposal is to expand those, recognising some of the best practice we've seen from elsewhere and the feedback, and really that some of those areas we have deployed the escalation framework is have really led into those and then into those spaces too. In line with that, we've reviewed and updated the triggers in those domains in terms of what will force a consideration of whether teams, so divisions or corporate teams, are in normal arrangements, enhanced monitoring or targeted intervention. So we've reviewed those triggers, and we've also reviewed the kind of the suite of actions that can be considered as a response to escalation. One to draw out that has been talked about definitely in the F&P committee and through execs is the option as one of those actions to bring teams into relevant committees to talk through improvement plans, so members can understand progress and challenges with making the improvements expected. And important alongside that, we've noted that the relevant exec director, recognising lines of accountability, is invited as well if they're not already a standing member of the committee. There are other actions added to those kind of that element of the framework that can be considered as part of the response. We'll continue with the at every F&P we have an update against our internal framework and the national escalation framework. So that committee will continue to kind of own and track the implementation, but also to note that where divisions or corporate teams are in challenge performance in other domains, that there's the opportunity for updates to those, which we haven't sort of done consistently previously. The paper does draw out some other key, it's not just about the escalation framework, some other key areas of development in terms of clarity on expectations through the plan and then through accountability letters. Work we've done to try to improve the performance reporting, make it integrated, and how we try to streamline and strengthen the actual meetings and the agenda for the meetings when that occurs. So that was what I was going to say, but happy to take any questions. I would like to just thank those who contributed to the review and the feedback. It's taken us a bit of time to go through and synthesize the information, but yeah, grateful for any questions and ultimately asking the board to approve.
Thank you very much, Hannah, to you and your teams for the hard work that you've undertaken in reviewing and renewing this accountability framework. Are there any questions or comments? Neil?
I'm not opposed to the idea of people coming to committees to face scrutiny, challenge, whatever. So not in principle at all. I do wonder, however, given that, you know, committee agendas are quite extensive, and one of the challenges for most committees is actually keeping them within a reasonable time frame, and potentially this, you know, could put even more pressure of that type on. Just time pressure, really.
I think that's a really fair point. It's something we need to work on. And just to sort of emphasise the point again, it's part of a menu of actions to be considered. So I wouldn't suggest it would be the first port of call for a team or a corporate team.
I definitely support it if I thought it was going to deliver the result.
And I think maybe not through the lens of sort of a division or corporate team escalation, but we have started to, you know, so in F&P we brought colleagues from the theatres team when we did that deep dive, which is a kind of a lens on, and it's one of the other areas that's come through. We're looking at outpatients Monday, I think it is. So it's maybe how we use the time already in the meeting for that, and maybe think about how we use deep dives. But
yeah. And it may be that we create additional space for that, where we bring committees together. So we could look through in a more integrated lens at escalation, bring in QSOC and F&P together for a dedicated purpose. So I think using a committee to provide a level of scrutiny, but how we do that doesn't necessarily have to be core business.
Yeah. Okay.
I do think the point that I'm trying to make as well is that recognising the lines of accountability, how that's done with the relevant sort of directors. So if it was my information on there, looking at Leanne, because we talk about divisions a lot, that's just appropriate that that's with the relevant executive functions.
Yeah, so I think we recognise this is kind of evolving and we're trying to strengthen it as we go along. It was quite useful when we were going through some of the finance process recently, and with some of the divisions, some of them have adapted the similar type of approach with their directorates, where they've perhaps a bit more mature in that area. So it was quite good to see them putting their own kind of approach to it and implementing that on the structure. So I think it's got the potential to become more embedded as we become more mature with this process.
Are there any further comments? Are we happy to adopt the updated framework?
Yep.
Yeah, thank you. We'll move on then to 5.5 General Mental Services. Yeah.
Thank you, Chair. Two papers, both in relation to changes to GMS services within Ira Bevan. The first paper relates to Aberbeeg, which, as the board will be very well aware, was a managed practice. We had been approached by a number of local GPs, because I know there'll be a nervousness around sort of advertisement of some of our GMS contracts, given some of the issues that we've had. To say that they would be interested in sort of taking on sort of a local that contract in particular. We went out via the vacant practice panel process. We received 2 bids. One proceeded through to interview, and that one was an existing practice we have within our footprint already, Cwm Surgery. And the panel recommended the award of the contract to Dr. Sean Nye and Partners. Just for awareness, Isolde is also one of our NCN leads in Blaenau Gwent too. So confidence levels in terms of, I guess, the altruism of the provision and I guess sort of alignment with our values and what we expect for our GMS contracts, I think is high in particular on this. So just would support board endorsing the decision to award the contract to Dr. Shaw, Nye and Partners. Just by way of update, because of some of the issues of timing, the contract award would commence with effect from the 1st of January and not the 1st of December as was originally anticipated. So that's the first paper. And then it's
pause. Pardon? Can we just pause?
Yeah, sorry.
Are we content to note
Yeah.
the recommendation? I think certainly it's been scrutinised well. Yes, you want it?
It's just a question, given the issues that we've had over the last few months, etc. And we say in here that we've asked for further financial information. Have we had cash flows, financial projections? Because that's where we fell down with the last partnership. Harley Street was more or less around cash flow, and they were running out of cash, in order to pay their employees, etc., etc. But we had that on these. Are we going on trust?
They are.
Have we seen those cash flows? Have we had comments from their auditors? Do we know the corporate structure? Because that was incredibly complicated around Harley Street. So the things that we fell down on the last one, are those in place for this?
I think there is a significant difference in terms of Dr. A&A. I think in terms of the previous award, because they were not necessarily, I think, sort of an existing local GP for us, whereas this practice is in particular. I think as board will be aware, we are.
I guess my question out of that is, have we seen the finances of how this current practice is operating, so that we can project forward to then how they would operate a new practice? Have we got that information in place?
No, we don't have that, and we don't. We're not entitled to it.
That's going to be my next one.
Yeah, no, as part of
Who is checking this information? I guess we are going on trust that somebody is operating their current practice well, to then saying, oh yeah, have another one, have another one, have another one. And that's kind of what happened with Harley Street, if we're perfectly honest about it. Do we check all this cash flow information? Did we go into this kind of financial level of detail?
I sort of speak for you, Rob, but the procurement process for this is different to the previous procurement process, because this has been done in line with new provider regulations. So the procurement is a much more robust process. It's around.
Okay, but I would look at, if that procurement is more robust, did that procurement process look at, or did anybody look at the financial position, the cash flow, audit comments, the things I would look at if anybody was, or we were buying any business or anything like that was happening externally. It's fairly standard financial information.
Okay, so personally, I can't say yes or no because I wasn't part of the process. However, the process does require, it's in the Workforce Quality Services Provisions, Business Continuity, Sustainability and Financial Review. We can certainly go away and have a look at what that content was, but I would presume that all those things would have been tested through this process. Okay, I haven't looked personally, so I can't comment.
So where is that for us, that kind of financial, from my point of view, where is that financial sign-off to say, yes, the financial sustainability of this business has been reviewed and here's the sign-off on it?
Well, that would be part of the process.
Yeah. All I can't see from this is
it's not captured in this paper, is it? But none of the other bits are either. So I think on that level of detail, we probably have to pick that up outside.
Well, I guess from an assurance point of view, what we're being asked to sign off on is that the process has been followed, etc., and it's in place.
So I think one of the Wales Audit are actually doing some work on this. I think on the back of some of the issues in terms of what have been the historical processes around financial due diligence when we award the contracts, and what should be the financial due diligence of when we award the contracts. And like Rob, I'm not aware of the level of detail we go into, because if you take when we've got 70 GP practices that we don't get involved in what their financial positions are today or yesterday. And there's also, I would reflect on our experience is we might not have picked up an issue of financial due diligence at the time we awarded the new contract, but the new contracts created a financial problem for them that possibly weren't predicted. I'm making kind of the insight I've got. So I think
we're in that same position with this practice.
So what we need to do is, which Rob can kind of follow up, as you said, the due diligence should be built into the procurement process as it currently stands. So we need to make sure that's done, which that we haven't had anything that suggests isn't. And there is a national piece of work to say, is that sufficient? Should we be doing anything different going forward? But we just need to, we are assured we followed the procurement process from where we sit today, which is why we're making the recommendation. What we can do is provide additional information as to what that looks like. Because some of them haven't got through to the next stage if they don't meet some of the criteria.
We followed the procurement process last time, maybe not last time, but what I mean, around the practices that we had and this one as well. But nothing then seems to have changed for this one. I know it's an established practice and all the rest of it in our region, etc., etc. But there's still that level of assurance that seems to be missing out of the procurement process. If it's been brought to us to sign off on, sorry.
No, just to clarify purpose. So this contract has been awarded. The board isn't required to approve that. I wrote to the board on the 11th of August advising of the contract award, recognising this meeting was going to be some time away. So purpose of this paper is that the board notes the contract award for the purpose of the public.
Okay, so I'm raising my concerns around whether or not there are additional steps we should have in these procurement processes that we should have in place, whether it's in place or not, but.
That's what I'm about to say. I can check what the additional steps are. And
yeah, because the last thing we want is in another 3 months,
No.
somebody coming back and saying, we've run out of money again.
Yeah.
I think there is.
But also, Wales Audit is undertaking a review for us in our request, which shouldn't be too long coming, should it?
Can I just add one thing? Given what has happened in the past, again, I wasn't party to it, but I'd probably say there's a lot more scrutiny than beyond standards required on any future words. But I will.
Yeah, I think we all hope there should be hope that, but there's nothing in front of us to say that has been done.
So,
my concern.
well, better than those benefits.
Obviously, we also had an internal audit on the last set of procurement processes, and there were set recommendations from that, one of which included that there should be greater financial due diligence done on procurements. And the response to that was that there are new procurement regulations we should be following, and we need to look in more detail. I think the thing that I'm missing from this paper is just what was the extra due diligence we did, so that we can have confidence that this was done within this met the outcome of that internal audit that we had done before. Because obviously we all said that in retrospect, if we'd done more financial due diligence, we might be in a different position. So I'm sure we do next time.
Yeah, so I would suggest the issue isn't financial due diligence, it's the whole plan. That's what fell down last time with the other practice. So the plan was considered reasonable but ambitious. Without repeating everything you said before, there were elements of how the practice implemented that we were able to implement that practice. Caused the problem. So I'm not sure, I wouldn't suggest it's just a financial assessment, it's actual a whole plan assessment. So just want to draw that out so we don't just focus on pounds. It's not about pounds, it's what drives that.
Benny? I just want to ask a quick question. Did you say they were established local GP surgery?
Oh, so NCN leader as well, right? She's one of our NCN leaders in Blaine Gwent as well.
So logistically, it won't be hard for them to take us in. That's all I want to know. Thank you.
And it's the neighbouring practice, and the patient cohort is small in the context of other practices. We're talking about 4,000 to 5,000 patients as opposed to 20,000. So it's a comfortable one, and recognising Rob's comments, the thing that was arguably missing in previous exercises was the workforce plan. A little bit like Lantrison Health Park. If you haven't got a defined workforce plan, then your financial forecasts and flows are always going to be ambitious and ambiguous in equal measure. Whereas I think this is constrained and it's an easier one to understand and support.
Akmal?
Just a quick one, Chair. I think I agree with Rob in terms of the whole plan. And one of the things which I feel is very important that should perhaps is already included in the plan is the succession planning. because a lot of the GPs, it's getting very difficult for the succession. So if we are getting into a new contract like this, I think we need to know what is the succession plan as well, because we could also lose out in terms of the financial issues, but there's no succession plan.
Yes, I think that was one of the things that added to the positiveness of their application, is that they have sustainability, they have more. So we will urge the WAO to come forward with their proposals, which will be helpful, and we will seek then to influence the national contract if anything is required to change. But in the meantime, I think we've been quite lucky to get a local general practice to take up this small surgery. And we note the content of the report and we will monitor it very carefully indeed. Okay. Yep. Thank you. North Cullinan. So the second paper relates to a request from North Cullinan Practice to close Newbury branch. At the moment, current provision is 1 clinical session 4 mornings per week. The request to close the branch is as a result of an existing lease coming to an end in December. And there is a proposal from the practice that they reinvest that money in sort of service provision rather than on lease costs. We have run an 8-week consultation in line with the branch practice review panel process, with only 9.3% of the patient population responding. 56% outlined no concerns as a result of the change, with 36% raising concerns in relation to service reduction. But we know financial and workforce sustainability is a key arm of GMS contracting and sustainability sort of generally. So I would ask the board to endorse the recommendation of the branch practice, a bit of a mouthful, review panel to close the Newbridge branch surgery in line as has been outlined in the paper. Thank you. There is some further work to do with local community around parking in terms of the existing surgery, but that will be ongoing.
Any comments, questions? I did note that it was stated in the paper that not renewing the lease could be used to improve services. I do think we'd like to see what.
So yeah, I was just going to say exactly the same, but it's around those measurable outcomes that we expect for that 45,000 little increase in profit that they're building.
Are we happy to adopt that? Thank you. Now on for items for a discussion. 6.1, the annual quality report. Jenny, please.
Thank you, Chair. So this paper sets out our requirements under the Quality and Engagement Wales Act, which is to produce an annual quality report, which in the same way we have an annual, a broader annual report and financial report. Clearly, this sets quality on the same level. So what we've done is set out our achievement against the pillars. The paper also describes some of the other areas of work that we've been focused on over the last year. It also sets out our priorities moving ahead in terms of what we feel we need to focus on and how that aligns to our organisational priorities. So just a few achievements to talk through, and I'm very grateful to my colleague clinical execs, so Tracy, Peter and Andy, formerly James, for their support, and all of our teams worked very hard with the divisions to put this report together. So it's very much an organisational report. So in terms of patient experience and involvement, clearly we've rolled out the Civica feedback system. We have a satisfaction rate of last year around 89%. We still maintain at 87%, which is a real achievement. And we've seen an uptick with the advent of text responses, increasing the numbers of patients that are accessing the Civica feedback system. We have found some issues in terms of access, so people who find it hard to use a QR code or hard to use their mobile phone. So we are using paper responses as well and uploading those manually for those patients. Particularly stroke raised concerns around the electronic access versus paper. So we're offering both. We've also done a lot of work over the year in terms of the establishment of our patient participation panels. So we have one for neurodiversity. We are looking to set one up around deterioration. And as you heard earlier, we will be setting one up around early pregnancy loss. They're fairly new for us and for Wales, but well established in England in terms of a model of engagement. PALS has gone from strength to strength, and we'll be doing a formal evaluation against the original business case this autumn. But continue to see high numbers, around 500 to 600 patients a month who would otherwise probably end up in our complaint system or would be taking time from busy clinical staff in terms of that response to their concerns. We've increased our volunteer programmes and we continue to do that, and we're grateful to the charitable funds for supporting a post to look to see how we can go further. And as you know, we've done a lot of work on bereavement and sepsis and deterioration. From a patient safety perspective, we've tried to embed a strong learning culture. We do regular reviews. We have a learning and improvement forum, which is fantastically well attended by all of the divisions and all of the teams in the health board. They share case studies, they share learning, and we pick that up and take that into our improvement programmes. We've worked on divisional dashboards with Leanne's team and really starting to try and get our data into a place where we can start to have a more systematic statistical analysis of that. We've improved our compliance around closure of serious incidents, and that continues to go from strength to strength. And we have noticed and noted a downward trend in inpatient falls, which we think may be in part attributable to award accreditation and the pride team's place in their data and their audits, but also that early identification and prevention of pressure ulcers. Again, we've seen a real impact there, and both of those have been subject to quality improvement programmes at an organisational level. We've obviously have active participation in national clinical audit programmes. There's work to do on local clinical audit, but we have a plan. And we've obviously been one of the first organisations in Wales to implement a learning from deaths framework, which is based on the English model, which I think is really important in terms of how we learn from patients who've died in our system. We've launched a QI coach programme. We're on our third cohort, and our QI coaches are across the divisions and across the organisation, and they are working in particular with some of our wards. So to get ward accreditation, the teams have to have a QI project. So many of the coaches are working with on the ground teams to lift those projects up and to apply the methodology. We'll be working with Leanne to try and make sure we wrap around some of the priority programmes that we have in place. And certainly the theatre safety programme has been a real success in terms of the reduction in never events and some of the other theatre safety work that we've had in place. We've also had a real success in terms of the head and neck QLab programme. So we've managed to avoid 7 potential deaths and halved the number of days for treatment of cancer. So some real tangible improvements in terms of the impact of QI. From a health and safety perspective, we've seen improved rates of training, which has been fantastic. Further work to do on manual handling, but improved rates, certainly in fire safety and violence and aggression. And working with Scott and my team, that improved incident reporting and management. Until this month, we have seen an improved position on our infection prevention and control. We've had work on enhanced cleaning, improved antimicrobial stewardship, but I do note this month, and I'll come on to it in the next report, we have seen a slight downtick in our CDIF performance. And safeguarding adults, we continue to see that strong interagency collaboration. We've increased our safeguarding reporting, particularly in children. And obviously we've seen a huge improved training compliance around level 1 and 2, further work to do on level 3. And I'm very pleased to say that we've got 78 areas and teams that are now in the board accreditation programme. There's a real competition for people. People are desperate to be the first to get to gold. We haven't got a gold yet, but we've got 7 silvers, and a real sense of achievement in areas that are really striving to achieve that. That brings with it local audit, it brings with it local improvement. And as we say, we're going to do some work to try and show cause and effect with some of our data around safety. And just before I pause, I think, you know, the other 2 areas of work where we have seen significant improvement are around human factors. So in safety science, human factors are really important in terms of rooting out unnecessary variation in safety and ensuring that we identify system and process issues which impact human error. And we're leading the way in Wales in terms of the development of human factors and our science around that. And I'm very pleased to say that we have 2 local champions, 2 clinical champions who really champion and take forward that work. And secondly, our work on deterioration and sepsis. As you'll know, we've reported previously, we've seen a real impact on some of our acute wards around the QI work, but also the way in which we focus with families around how we identify acute deterioration, how we implement the call for concern and Martha's rule, and how we then translate that into a sepsis programme, which I know is technically Q1, but the planning will have happened in the last financial year. So thank you, Anne. Our priorities are set out in the plan. I won't go through those, but I'm very happy to take any questions.
Thank you. Thank you very much for such a comprehensive report. Are there any questions, Penny?
Yeah, more of a comment really. The ward accreditation programme, which promotes a culture of continuous improvement, that seems to have been a great success, as you just said, 78 areas, which is brilliant. And it's just, it gives people a sense of ownership, I suppose, belonging. And, you know, from first-hand experience, I've noticed that on a ward, it's a team spirit, which incorporates everybody who works on that ward. And that is so important. It's almost like going back to the old days, said the old one. But it is, it's fantastic. But just one thing, the monthly checks are great, obviously, but just one of the downsides was that they found that the regular audits were time consuming. The staff found it to be time consuming. I wonder if there's anything that, you know, could be made easier. So an easier format that can be developed perhaps in the future.
Yeah, we're continuing to look at how we can work with Paul's team and you know, with my team to try and improve the time it takes to do the audits. We load them all onto AMAT, which is, you know, it's a good system, but it does take time to do that. I think the teams actually, whilst it does take quite a bit, you know, it does take time. I think they quite enjoy doing it because there's that sense of pride. But we will continue to work with our digital colleagues to see how we can start to improve the sort of functionality of that and to make it a bit more timely for them, because it is an issue. But you'll have seen, you commented on the boards, and the boards, Penny, they're all the ward accreditation boards.
They're so proud. So it's great.
Thank you. Peter.
Just a comment on ward accreditation as well, and the work we're doing to take that forward in terms of looking at teams and services rather than just wards. And really excited that we're going to do that with the mortuary team as an area of our service that we do a lot of improvement work in, and I think that'd be really, really good for them as well. Yeah. So the opportunities of ward accreditation or no service accreditation are really huge. It's really good.
Good. It is really stimulating for the people who operate it. Yeah.
And I think the competition is interesting.
Yeah.
They're looking over to the next place to see they got it.
Exactly. I noticed that inquests seem to be rising. Are the criteria changing, or no? It's just that we've got more patients coming through, more people.
I'll defer to Andy, but I think it's multifactorial. The ME process has definitely had an impact. Yeah. The coroner's actually been very supportive. I met with her 2 weeks ago with the divisional nurses. I think she wants to try and work with us and to minimise the impact. She's doing more inquests in writing. Some of that is about the quality of the work we do. But Andy, do you want to comment on
the additionality of the ME service that's driving it? Right. And I think until that service matures and defines itself a little easier, then we're going to have this additional burden.
Okay, thank you. Are there any further questions on the quality report? No, well done, and thanks to all the staff involved for driving this. The putting things right report then.
Yeah, and what we're going to do for next year is try to combine these two reports because under the legislation we feel we can do that, and I'll work with Ronnie to make sure that we meet the regulations because obviously we're still working with the old PTR regulations. The new PTR regulations should go through government next April, so we should have a new set of PTR regulations, and we'll no longer call it putting things right. Will be a much more patient-centred title. So to avoid the duplication, obviously I didn't mention it in the previous report, but clearly the PTR regulations are a core part of our new quality management system and our quality management framework. So we've embedded the new governance around quality, and PTR is key to that. We've embedded that across the health board. I'm pleased to say again, I think we're the first health board to embed a quality management system. We're certainly one of the first. So I'm very pleased that we've done that work and being able to take that forward, supported very ably by Ronnie in advising us on the governance and the accountability. But just some quick key facts and figures. So in the last year, we resolved 1,656 concerns early. So in the first 2 days, that 2 days we think will be extended to 7, which gives us much more scope to intervene early and to avoid formal complaints. And 1,518 were formally managed under PTR. So that's, that is a high number. We're not out with any other health board, but just in terms of the volume of PTR complaints. But we've done a lot of work in terms of trying to improve the process. We've done a lot of work on communication standards. We're still not perfect, but trying to work with people who've been in the process a long time to make sure there's timely communication, that we aren't leaving it until the final letter after it's been 6 months, to make sure that we're updating them along the way and working with them. And we've done a lot of work on learning and improvement, so trying to make the join up with the listening and learning framework and trying to make sure that we don't just focus on, the sort of themes that they're pulled out of Datix, trying to understand what sits beneath some of this. Rachel's story is a really good example of that, where it came in as a PTR complaint, but there was far more to it than just the issue of the scan. So it's really important that we understand the nuance of some of this, because that's how we identify themes, that's how we identify the learning to take forward. We've obviously had the big conversation events. We've held a number of those now. They've been really well received, particularly by people who've been through complaints process. We did hold one for early pregnancy loss as well. So we've done a number of those across a number of different themes. And we've had multi-faith, multi-organisational public support for that. So, and it's been really valued, I think, in terms of people feeling they can contribute, but important, I think, to the PTR process. We do log compliments through the PTR team as well, but we're going to do a piece of work with Sarah looking about how we might do that a bit more systematically through a pilot of an app, because we know Datix isn't the best place in all circumstances to manage compliments, and we know that a number come through comms. And just from a claims and legal perspective, our personal injury claims have continued with a 16-year downward trend, which is quite interesting. So they've reduced systematically over the last 16 years. But we've also seen the number of ombudsman's cases picked up to have dropped. So out of 170 odd cases, we only had 6 that were formally investigated by and upheld by the ombudsman. That's a real testament to the quality improvement, even if we're not in the place we need to be around the timeliness with 30-day closure. And some very positive feedback to the team from the ombudsman directly and to Nicola around the work we've done to improve our learning, our timeliness, and our quality of work with complainants. We aren't where we need to be on the 30-day working day target. We were measuring it wrong, but it only gave us a couple of percent. But we continue to focus on the working day target. And during this year, we're going to be working with divisions to try and see if my team can draft responses for them. So they will complete a template, do some initial analysis, and we will then pick up the formal response. We're going to do a pilot with medicine to see if we can implement that, and we think that will make a huge difference I really commend the report to you. We identified a number of priorities for the next year. One of the things we need to get underneath a bit better are some of our very complex cases. We have some very challenging cases where we will be in process for a long time with complainants, and we need to find a different way of working with those individuals. We're currently engaging with some of the psychology teams within the organisation to think about how we do that and how we do that differently. And I think, again, that will help us, particularly for people who come back through the process several times. And finally, the last thing I'd say is that obviously we've implemented the statutory duty of candour. We are identifying those cases and enacting the duty of candour. There's further work to do on compliance, but that's a national issue in terms of DATIX being able to record that. So I'm going to raise that nationally in terms of we really, really need to be able to report compliance, because whilst identification is really important, compliance with informing people is also pivotally important. So I'll stop there.
Thank you very much. And it's really good to note the real improvements that have been made in trying to consolidate communication with patients and relatives and assuring them more effectively than we've been able to do before. So that's good. Well done for the teams. Any comments, Ewan?
Yeah, I think it's a question I asked before and I can't remember the answer. It's around the overdue ones that we have in there at the moment. Is that the appropriate description of them? Are they overdue because we haven't done anything wrong, or are they more overdue? Are they classed as overdue because they are complex, we are working on them, and it just takes that length of time, which to me isn't overdue as such. It's if we haven't gone back to somebody on that's overdue, but
it'll be a mix. It'll be a mix of both. So there will be cases that are overdue, which due to capacity we haven't got to, or the investigation is taking longer than expected. But there will be cases that are really quite complex that take a longer time.
So are we able to split those at all? So we know, like, that's something we need to kind of slap on the wrist, we need to get on top of this, or is it just, or are they the ones that are complex and we just taking time to resolve? It's not really overdue then as such.
No, it's a bit like the NRIs, because with nationally reportable incidents, we set the time frame. So we can take up to 120 days, you can take between 30 and 120. Currently, there isn't that flexibility within PTR, but I think, so although Welsh Government would monitor us on the 30 working day, we could certainly start to try and split some of that out so we can identify, you know, those that are truly overdue because we haven't got to them, and those that we are working with the families and it's a work in progress.
Yeah, because that would be interesting to see how many are, because they're not really overdue if we're working on it kind of thing. I think we're kicking ourselves for no apparent reason with those then. You know, if we haven't gone back to somebody within 60 days because we didn't have the resource, then that's the slap on the wrist bit of we need to do something.
I'm sure we can start to.
I would imagine there are very few of those, to be honest. I would guess there's more on the complex side. I would guess.
There will be quite a few that are on the complex side, and of course we take the duty of candour very seriously. So we set ourselves very. It doesn't always work, and Nicola and I will receive this frustrated people, but we do try and make sure that we really understand what people want. So we really try and understand their questions. We really try and understand what they're looking for as an outcome.
And that's the thing. If we're communicating with someone and we're keeping them in the loop of things, and it's not overdue.
No, they wouldn't call it.
No, they wouldn't call it overdue. No,
neither would I. We're working on it.
Paul?
Can I just say, I think it's a terrific report, Jenny, and to thank all the staff who've been involved in its production and the excellent work. For me, it says it all on page 409, with his 12 million patient interactions. Now, when you look at the numbers of that you've got there, the other issue that, so well done for that. The other issue that I think we've got is the sort of the culture which has come in from America, which is the no win, no fee culture. When I was coming down to the meeting today, and along one of the radio stations, and it was sort of saying, don't forget, if you've tripped over, give us a ring. You know, you're thinking, well, hang on a second. I think the sort of culture of money, or the sort of compensation culture, which I think is a bit sad really, because that doesn't, it actually prevents people from wishing to say, well, I've done something wrong, because it's sort of this, that's going to be quantified with a sum of money. And that's what we also have to be aware of, I think, in terms of sort of the that particular culture, because I can remember I did some work elsewhere in the country, and solicitors were saying you are entitled to that because you're on paracetamol. And when you look at the actual guidance, that's not the case. So I think wrong information as well. So I think, but from our perspective, I think it's a very productive report, and I think it's all proportionate. I worry about the medical examiner timeframes, because I'm sadly a member of my family cousin passed away, and when I talked to my relatives, they were saying, well, we hope to get the funeral sorted. And I said, well, it's going to be at least 10 weeks, and they didn't quite understand that. And then I explained the medical examiner a bit, and they, oh, right, it was 10 weeks later when it was all authorised. And I think that may be something we need to look at to see whether that can be streamlined, or people can be given guidance on it, because there's a different time frame in England to Wales. And the question is, well, why is that, and what the impact?
There's a lot that's different in Wales. But
anyway.
yeah, we do have an end of life group, which Tracy might have theirs, which a number of divisions and directors are represented on. So it might be a good question to ask the end of life board to have a look at, because they'll be picking up obviously the bereavement conversations. They'll be picking up the end of life conversations around what that means. And we've got a really nice, we call it Grace. It's a model for end of life care where we have a different model of the way we interact with people. So we can bring it into that. I'll ask Tanya to have a look at it.
Well, I mean, I think it would be sort of, I think, difficult for some people who have a model in Wales, which is a long, lengthy process of delay before the funeral arrangements compared to other parts of the country. And I think that needs to be looked at.
It is an issue.
Thank you. Are we happy then to approve the report and note the key priorities for next year? Thank you. So performance reports.
Thank you, Chair. I'm going to be, I know we're pushed for time and they've got big agenda items to come, so I'm going to be really brief. Assume everyone's read. This is the integrated performance report up to the end of July. We do have some August information now, which we can pick up in F&P on Monday, because we have it in time to get into that report. But it also picks up the progress under each section. You'll see a progress against the IMTP deliverable commitments. So that's in there as well for this version. It wasn't too ready when we hit July board. So I just want to draw out, well, I'm going to draw out 3 areas, and then we'll talk about urgent emergency care and to give some kind of very sort of current information. So so just a few areas. So on cancer, just to note that we've been observing good progress in cancer in terms of the impact of the very process focus and tumour site focus task and finish groups. We have been sort of stabilising our performance, whether that be the single cancer pathway or the backlog of patients. We are seeing a slight dip in that. July was 63.5%, and we are anticipating August single cancer pathway performance to go under 60%. Couple of reasons for that, one of which is it picks up the summer period where there's elements of leave that do impact, despite the efforts to try to recoup activity. But really critically, referrals into cancer services are continuing to increase at a very significant rate. For example, since April this year, GP referrals for suspected cancer have gone up by 24.5%. So the kind of holding the position with a slight dip, still within tolerance, is quite an achievement really when you put that lens the referrals and the increase in referrals, which is significant. And some key actions in train to help support this. So, for example, dermatology now use of photo referrals. There's a focus cystoscopy plan in place as well to support the urology pathway. So I just wanted to draw out that on cancer. On planned care, and we picked up some of it in the context of Nicola and Chair's update on the National Outpatient Plan. We've talked a lot previously about the delivery against the 104 weeks target, and in line with as we predicted. So at the end of Q1, just to remember, we over delivered and got to 172 patients. And that is, as we predicted, now creeping up. We had additional investment for Q1 and the end of last year. We are on track, however, with our trajectory for just under 1,300 by the end of September, so the end of Q2. And what we will need to do on the back of the additional outpatient activity is rerun some of those trajectories to factor in the opportunities and risks and conversions for that additional activity. So we'll start to see some variations of trajectories coming through in future reports. The national outpatient stuff, as we've touched on, is now starting to ramp up. The health board, the teams are doing really well, notwithstanding some of the challenges. And we are getting going in a number of specialties. The next thing I just want to draw out is diagnostics under planned care. Again, made really good progress against the 8-week waiting times targets. That again has deteriorated a bit due quite specifically to non-obstetric ultrasound waits caused by a challenging workforce. But I'm pleased to say, through to the team's efforts, that's now back on track, and you should see that recover in future reports. From a mental health perspective, we've observed over the last few months great both improvement and then sustaining of key mental health performance. And have said focus will now turn to psychological therapies. I think you've probably heard me say that. So it's really great to see, now you can see in the data that focus has been put there, and they're making really great improvements against the 26-week standard, from below 40% to now 55% in July. So that commitment has tracked through. And then finally, just on urgent and emergency care. So we know it's remain internally and externally an area of escalation and focus. The data will show it's been a challenging period over the summer months against some of our key metrics, and our ability to sustain improvements in ambulance handovers and time spent in department and pull through department. However, we've talked a few times about the Your Next Patient initiative, which you won't see the data yet in this report. So I think it might just be helpful for Leanne just to hand over to Leanne's been leading this work, just to pull out any of the key hot off the press metrics that are starting to emerge through that. If that's
Looks great in her script.
Thank you. It was very important to show that I was there to support the teams. So as has already been alluded to, we went live with Your Next Patient on the 8th of September. So we're only a week just into the start of week 3, really, in terms of impact. Just some headline facts, because I would like us to do a fuller briefing for board sort of when the dust has settled somewhat, because there's a lot of work for us still to do. And we haven't, we need to make sure this is sustainable for people. But in the weekend before we went live with Your Next Patient, we lost 170 ambulance hours as a result of delays of ambulances outside on the forecourt. Of the first weekend that we ran it, we lost 20 hours. So in a week, it's been a miraculous, there's no miracle, hard work and focus and commitment from the teams. And I think a special shout out goes to the teams that have committed to this. We're running twice daily huddles at 8 o'clock in the morning and 5:30 in terms of preparedness, small tests of change to allow us to trial and test different things. And it's not just about ambulance handovers either. Just wanted to give some examples of patients being admitted into our hyperacute stroke unit within an hour, fractured neck of femur patients being conveyed in the morning and then into surgery in the afternoon. And they are very real patient that impacts on patient outcomes and then sort of the rest of their lives. So from a quality perspective, you can't underestimate sort of the benefit that when we get this right, there's no if about this. I think there's a commitment around this in particular from all of the teams around making a real change. We have last week, Nick is waiting for the dashboard to come out on a weekly basis. So we were amongst the worst in Wales, in particular around ambulance handovers. The Grange is one of the busiest sites in terms of ambulance attendances and arrivals across Wales, because of obviously sort of our model. But last week's, which is the last full week that we've had, and we would have only been just at the end of the second week at that point, we had, and they only count ED arrivals as well, which is not great because we almost double the number of arrivals when you look at our assessment units. 332 arrivals to Grange ED, with 85.8% of all patients being handed over within the 45 minutes. That was 4th out of 12 hospitals in Wales. And when you look at the volume and I guess the acuity of some of those crews in particular, that is, you know, outstanding. I think it really is. And before we went live with Your Next Patient, we had average lost hours per arrival was about 2 hours because we had some very long delays for those less acute patients. And last week's report shows us just under 15 minutes, so just about the 15-minute mark, which makes a huge difference in terms of our ability to respond to the community risk that we've been carrying, as well as I said, not making sure that patients are in the most appropriate part of the system to receive their treatment as quickly as possible. So I'm immensely proud of the team because it really has been a collective effort. Lots more work to do still, I think, and lots of opportunity, I think, in the system, and lots for us to learn, I think, both culturally and from an organisational perspective about how we approach transformation and dealing with intractable issues that we haven't that we haven't been able to resolve on. So early days yet, would welcome the opportunity to do a fuller briefing, I think, just to thank the team more fully, but I think lots to be proud of and lots for us to build upon.
Yeah, well done. It's a really huge effort that's been generated, and well done. And I'm so pleased to see that touch wood, it's working, because that gives you the drive to keep going. Penny?
Yes, so fantastic effort, and I really would welcome, I'm sure everybody would, a full briefing on it, because I'd like to understand what's the main contributory factor do you think brings out these excellent results thus far?
Culture, I think, really is a large piece of this, and focus. I think sort of those two things. There has to be a plan that sits behind it. There's got to be, in terms of the technical operational management and leadership around it. But I think a cultural shift of us coming together as an executive team. I've had full support from the clinical execs and us standing together to say this is not acceptable. We will support the organisation to make decisions. It is uncomfortable, some of the decisions we're making for teams. We are at times, being very honest with the board, trading off on experience for quality and safety, in my opinion. But I do think that is a transient issue, because I think if we resolve the issues that we're picking up, then I don't think we need to compromise on either, to be perfectly honest. But as I said, it's not we can't step away at this point. I think that focus and commitment and everyone pushing in one direction, I think, is a particular, I would probably call out at this point.
Great, thank you.
Thank you. Any more questions to Leanne? Keep going.
Yeah.
Congratulate the teams.
Thank you.
Thanks. Finance. Like you. Yes.
Oh, sorry. We've got policy and workforce, I think. Is that right?
Is there any, if you wanted to draw out for an integrated report, any workforce?
Oh, right.
I think we've done a lot of quality.
Yeah, we've done.
Just 2 points, but I'd like Sarah to go first.
Just to pick up by exception really quickly, because we've had a discussion on a lot of workforce issues today. We talked about sickness absence and the focus on absence earlier as part of the people plan. Just to highlight that I was party to a presentation by HIW and Public Health Wales in conjunction last week, and the trends that we're seeing in our sickness absence and the trends we're seeing by reason for sickness absence, particularly around anxiety, stress and depression, and mirrored across NHS Wales. Notwithstanding that gives us any comfort, but it's just to provide some context to our position. In terms of variable pay, we've been working hard as a team and with many of our service colleagues in developing proposals to address agency, particularly in medical workforce, and also some working with Jenny's team to consider some new options for nursing, and they'll be considered at Value and Sustainability Board next Monday. And just to note that whilst we've got a long way to go with our job planning, really pleased that mental health have reached over 90%, and also primary care and community have reached 100% over the last month. At the last People and Culture Committee, we had a discussion in terms of support from all board members in relation to job planning. And when you attend an AAC panel now, you have a briefing in relation to that directorate's job planning compliance. They're really helpful to support encouraging conversations to show the focus on achieving the 90% plus compliance with job planning.
Thank you. Any questions on workforce? The issue of productivity came up at the chair's meeting, given the increasing cost of the workforce and the increasing number. So I wonder what discussions have the workforce directors had about the measurement and analysis of productivity of our workforce, because we will be asked at some time.
So we've had some discussions around, what are the expected KPIs to indicate productivity, given that we focus on quite traditional KPIs. I was expecting an update from our professional workforce lead from Welsh Government over the summer. She wasn't able to attend our last peer group meeting, but I'll follow up in terms of what the expectations are, how we need to be looking at our data, being very focused about that request for productivity.
Great, thank you.
Sorry, I'll be very brief. Just in terms of obviously the data to July, we've commissioned 3, so a bit about the so what with some of our safety, intelligence and learning. We've commissioned 3 thematic reviews in relation to ligature risks, anticoagulant use in radiology, delay follow-ups, because we've had a number of cases where we've had delays in radiology follow-up. Our RABI remains in a positive position, although there's an uptick. We remain below our All Wales peers, which I think is a positive position given where we are, and that's the data to July. And the only other thing I wanted to highlight was that our QPS early resolution performance has had a real uptick. We've had a bit of a change in process, so across May and June we've had an uptick, and that's been maintained, and we've tried to ensure that we really focus on trying to maintain that early contact. But again, we've picked up themes and trends around particularly patient care issues, so clinical nursing care quite often, and some concerns around discharge, which obviously I'll pick up through the integrated discharge board.
Thank you. Any questions to Jenny? No? Well then, Rob.
Thanks for that motivational introduction. So I'm going to speak to the reports in the papers. It's the month 5 report year to date to the end of August. The position is reflective of the early mid-year review we've undertaken and the board briefing session that was held on the 10th of September. We're conscious a lot of this will be familiar. In terms of month 5 year to date position, we reported a £10 million deficit, which was £900,000 off our IMTP profile plan. Capital, cash and our public sector payment performance are all online positive. I'm now going to talk about the forecast, which is less positive. So our forecast has moved from balance to £19.9 million deficit. Following the Q1 review, we did start identifying an emerging risk to financial balance of up to £40 million. Now that was driven by unidentified savings at that point at month 3 and new year pressures that were emerging at around about £20 million for each. So hence the £40 million emerging risk that was reported to the board and reported to Welsh Government consistently. On the basis of that emerging risk, before this was raised, we held a couple of sessions with yourselves informally and in committee. So following a focused financial recovery period during the last couple of months with budget holders, we've managed to increase our savings and financial recovery actions, and our savings between Q1 and reporting month 5 have increased by over £20 million to a £42 million forecast delivery. There's obviously still a degree of risk with that because some of them are future dates, so we've got some uncertainty. But there is confidence in that £42 million savings delivery. A lot of those savings and financial recovery benefits are non-recurrent. So we will have to do it's ongoing now, actually, an exercise to determine what this means for our underlying position. Having an adverse impact against those additional savings are the assessment costs that are driving our deficit. So they're predominantly new year costs through inflation or growth being above the 1.77% allocation funded and operating pressures that we're seeing in the new year. There's a schedule in the report that identifies that, and that's really driving our 19 deficit. Because the 42 million savings are in excess of the 40 million MTP plan savings levels. So that reported forecast deficit of 19.9 excludes certain risks that are significant and subject to the discussion at the national level. And they include the Welsh Risk Pool, which initial estimates were £7 million. A report received last week by me could be as much as £16 million for the Health Board. Now that affects all of Wales, and we're doing some extra work on that, working with shared services nationally to understand how that's come about. We've also got the Band 2 to 3 national regrading proposal, which we need to work through and to do that. That's a national issue as well. And we've touched on winter, and the fact is we don't have a funding source currently for any additional costs related to our winter plan. So you can see our position is challenging, to say the least. So moving to what's driving our forecast, and I won't go through all the elements of the table on page 4, but it's predominantly things that are above the allocation that we've received and above our estimates of growth that we assumed. Key points: national insurance costs for employers. There was an unfunded gap of £2 million from Welsh Government. We've had to continue with surge beds and ITU pressures of the order of £4 million, even though we are seeing good performance on our delayed transfers. Responding to cancer of approximately £2 million. Drugs cost increases and volume increases. So now prescribed drugs, 2 million. CHC, 2.5 million, driven by growth and price. Mental health, 4 million. An element of that CHC, an element of that is acuity and enhanced care requirements beyond previous years that are really driving pressures for us. Report goes into more detail. As a board, you've received a full briefing on that, so I won't go further into that. In terms of month 5 year-to-date position, our pay costs and our non-pay costs are both similar run rates to what we've experienced in year-to-date. They have increased in month 5 because the implications of the backdated wage award, when you factor that out, pay is probably the same when you factor that out for non-pay, because we have pass-through arrangements for some of our care contracts. That's similar run rate as well. Both CHC and prescribing are holding a similar trend, so it's pretty flat. But that flat trend isn't reducing for the year to date. Our reserves are currently being held at £1 million. The balance has been put into our bottom line. I've mentioned about the underlying position. We'll need a rework and some focus on that. And to conclude, I think the message really will be we do need to keep going at opportunities to be identified, what we can go further at to both mitigate any cost pressures, potentially manage some of the risks I've mentioned, although they are very, very significant values, and deal with potential and pressures not being funded. So really the drive is identification of new opportunities to improve the position where we can and manage risks. There will be, I suspect, a request from Welsh Government following submission of an accountable officer letter that I mentioned earlier to determine and identify how we can effectively achieve financial balance. It's already been asked informally. So we will need to look at those opportunities. The potential opportunities that I would suggest will need more quality impact assessments to evaluate what it may mean, because I think we're in the realms of to achieve financial balance, potential patient service impacts.
Yeah.
Thank you.
Thank you, Rob. We've had no formal response to the decisions we took recently. Are there any questions for Rob? Neil?
Just a comment, really, which is that I noted this morning that HMRC were making a lot of noise about how AI had been used to increase their catching of frauds. And I would just like to say that, you know, I still believe that there exists so far unidentified and unspecified, but no less real opportunities for us to seek ways in which the adoption of AI can help us both improve quality of service and save money at the same time. And I still believe that, and would like to encourage any progress we can make in that direction.
I'd agree with that. And see Paul got his hand up. I think that the challenge we have is the investment before the saving at this point in time.
We can,
in an annual cycle of being held okay.
Yeah, we can talk separately about that, but I think there are ways around that that don't necessarily involve us having to spend a great deal of money. But that's another conversation, I think.
Paul?
Just a couple of comments on that. So obviously there are some work that we are doing. So there's been some great progress from a diagnostic perspective in the use of AI, and that's going to continue. Obviously working closely with Microsoft on their Microsoft Copilot, which I think plays into the productivity and efficiency discussion you had earlier, as we've done an initial rollout and looking at where we take that next once we've done the evaluation of the benefits. I think the key point is we've got to get our foundations right first, and AI needs data. Until we get our data strategy underway, till we start moving our data to the national data resource, that will open up then huge opportunities for AI. We got to get some of our foundations right as well.
I agree with that, Paul. I think that I think it depends on how we scope the adoptions here, because I think there could be sort of small scale tactical wins. I mean, it's interesting. I don't know in this room how many of us have got Copilot already on our machines here and are using. I know you are, right? And are using that, you know, and that's that has nothing to do with data. That has everything. Just that's AI-based technology.
But all that data is now in our Microsoft 365 ecosystem. So the work we did in the pandemic to migrate everyone into 365 has now enabled us to leverage those new technologies that have been made available. And as part of the new agreement with Microsoft that's currently being negotiated, we are obviously looking at accelerating course across the whole of NHS Wales.
So we won't lose track of it. Yes.
I mean, just to add to that, I think there's a couple of areas that we need to be a bit careful on some of the AI announcements coming out of organisations like HMRC. I think we've seen a number of studies recently, not least from the Department for Science, Innovation and Technology and Department for Business, where they actually haven't seen any evidence of improvements in terms of performance and quality from tools like Copilot. And similarly, some more recent studies from MIT that show that, particularly in medical situations, there is a risk that you de-skill medical professionals by through the use of AI, and it creates problems later on. So we do need to balance that. And Paul is definitely right that there's a bit of need to get the foundations in place to make the best use of it. And there is a big assumption that throwing AI at problem is going to solve it, whereas actually it's layering more and more stuff on top of poor foundations. If you don't fix the foundations, you're not going to get the real benefits from it. So you've got to be really careful about how you apply AI and applying AI in the right places. And I think there's a lot of unintended consequences that we've got to be wary of. So we absolutely do need some targeted thinking about how to do it, but we also need to tread carefully because particularly when we're dealing with, for example, patient data or other things, there is a risk of unintended consequences and quite severe unintended consequences from AI.
Yeah. Thank you, that was helpful. Anything further? Can we move then to 6.3, the annual report returns your neonatal services?
Thank you, and I'll assume the report is read. Just a few key facts and figures and just a bit of background. So see this report, I think it's the first one we've got in terms of a maternity and neonatal annual report, but clearly we support around 6,000 maternity bookings annually, so not insignificant. That translates into around 5,300 births. And we have services that are both obstetric-led and midwife-led pathways, as you know, with centralised care at the Grange. We've got 4 birth settings, so women have choice. Home, freestanding birth centre. We have an alongside birth centre at the Grange, and obviously our obstetric unit. And obviously our neonatal intensive unit is a tertiary specialist unit with a full range of intensive care, as well as high dependency and low dependency care. And you'll know that we don't currently have a transitional care unit. We're the only health board in Wales that doesn't, and there will be a business case in the future to address that. Just some of the highlights in terms of the paper and the improvements. So there's been a lot of work on early access to antenatal care. We've now got a self-referral system called SPA, which might make it easier, a single point of access. But that's leading to more women being booked by 10 weeks of pregnancy. We've seen real improvements in some of our public health data. So this report is 2024 calendar year. So positive trends in terms of vaccination uptake and ongoing efforts to address smoking, women with a high body mass index and substance misuse among pregnant women. And you'll know that we have particularly high areas of deprivation where we provide a lot of targeted support, particularly for women in the antenatal period and preconception, working really, really closely with Tracy's team in terms of some of that public health access. From a maternity perspective, we've obviously implemented the digital maternity record system. We are first in Wales. I like to say that, but that's enabled real-time data capture. There's been some real benefits of that system and improved information sharing, giving that enhanced oversight of care. It gives women choice, it gives women freedom to look up information, and obviously provides that two-way processing of information between us and the women and their families. But it also gives us the ability to look at dashboards and look at KPIs. So a real plus in terms of the work that's been done. Our birth numbers remain relatively stable, but we've seen a notable increase in caesarean section rates. So for 2024, it's 41%. That's a significant rise in terms of caesarean section, largely due to our areas of deprivation and increase in women with a high body mass index and gestational diabetes. So a significant increase. And we've also seen an increase in our reduction of labour rates as well. So further work to do, which we pick up through the early years and the maternity improvement plan in terms of how we support those women. There is an element of choice as well, and there's a lot of debate about the NICE guidance on choice. So women choosing to have a cesarean section, there's something about the information that women have, there's something about understanding the risks, and I think that there needs to be something looked at on an all Wales basis in terms of the impact of women choosing proactively to have a cesarean. It's not always the best you know, most positive outcome, and I can tell you the recovery is quite difficult for women after cesarean section, which it's quite interesting. So we need to get back to normalising birth. So there is a group that are looking at that. In terms of the neonatal unit, it's a very busy unit. We are full capacity most of the time. The neonatal unit participate in something called the National Neonatal Audit Programme. We perform well in most measures. We are below the average on one area, which is non-invasive ventilation. That data is published publicly. But actually, when we've re-looked at that data, actually, what we're providing to babies as an alternative to non-invasive ventilation is actually improved outcomes. So we are taking that through our governance processes. So perform well on the National Neonatal Audit Programme data. We have robust incident reporting across maternity and neonatal. We have a maternity and neonatal assurance and improvement group, which my deputy chairs, which focuses on the data around maternity and neonatal care experience. We have a service user on that group and also focuses on some of the incident reporting. In terms of neonatal unit, we have had some concerns in terms of infection prevention and control. The service are working towards something called ANTT Gold accreditation, which is an aseptic non-touch technique. So encouraging good IPC practice. And both services have a quite detailed improvement plan, which picks up many of these areas. Medication incidents are another thing, particularly in neonatal and particularly prescribing errors. So Andy and I have been working with the team to try and ensure that we have robust actions to address that. Both services are in a positive place from a workforce and recruitment perspective. From a sickness perspective, there are concerns on neonatal on the neonatal unit, but that's being picked up as part of the improvement plan. Just to finish, really, there are two other issues just to bring to the board's attention. So bereavement care and mortality reviews. So there's a very complex international, national and local system of looking at mortality, both for stillbirth and for neonatal deaths. And reporting is different to different parts of the regulatory system. So it can be quite confusing. We've done a deep dive into mortality and you'll see some of the data within the report. But on the VON data, which is the Vermont Oxford Network, which is a global network that collates data and reports back to organisations, I'm pleased to say we are below the benchmark. So that's pleasing in terms of that international benchmarking for mortality. There's quite a lot of work that both units do in terms of bereavement care and support for women and their families, either in that stillbirths or neonatal deaths. So a lot of work, and both services have really active and well supported parent networks. So we have the Babby Group and the Dinky Dragons who really do a lot of work with families on the unit and to support each other post discharge. We have commissioned a listening event in the neonatal unit that's been well supported by staff. That's independent to the unit, so myself and Sarah have commissioned that listening event to try and ensure that we have the safest, most positive culture within the neonatal unit. And following a meeting with staff with myself and Jane Beasley, the head of midwifery, Jane and I are also going to commission with Sarah a similar event in maternity. As we know, maternity is a hotspot. It's quite a high pressured emotive environment. So we need to make sure staff are supported.
Thank you very much. Any comments?
Yeah, just to add on the badger that board might be like to know that over 9,000 expectant mothers have been using the app that they can get on their own.
Good.
Smartphones, and that's really seen improvement. It's
brilliant.
Just helps drive the interventions, and it's also improved access to information as well. We've had really good feedback on the use of the app as well.
Good. Well, that's good. Good to know. Any comments on background?
Yeah, just a small comment on the expecting mothers with this new sort of news coming up with the paracetamol not being recommended. Whatever. Have we taken any sort of stand on it or did any app or whatever information that we can send?
Just before Andy comes in, I know that the Chief Nursing Officer for Wales is looking into, from a Welsh perspective, what response we would give, but Andy can talk.
Yeah, I've been in contact with CMO as well, so there is an expectation that a consensus message will be given by NHS Wales to address that. I don't think it's wise, probably, for each health board to give a local message.
No.
But there is no evidence that President Trump's assertions are valid.
Yeah, and just on that, once we've got that, we'll make sure we communicate to our local channels in terms of that national message.
Yeah, one message to be consistent.
Yeah. There's a lot of work going on today from a performance perspective and linking with the professionals at the national level so that we can respond quite quickly before it gathers any momentum.
Yeah, it's quite a lot of numbers as you're mentioning. Yeah.
Just on a slightly different matter, that you did mention about the staff absences and there's a huge variation between the various groups. One thing I just want to check, what is the difference between the registered nurse and the maternity inpatient? Is that different nursing components?
So no,
Sorry.
so the maternity, so we've split the data, maternity inpatient, which is obviously the staff in the hospitals,
Okay.
the maternity community and the community staff, and we've further broken that down.
Okay.
So it's not additional, we've broken that down into RN, healthcare support worker and admin.
Thank you. And if, any support you would need from the trade union perspective, please let us know.
Absolutely. So in both listening reviews, we have trade union representation. I should have said that.
Yeah.
Thank you. Good prompt.
I think that only one point for me, and it's a very encouraging report, is the issue of leads that emerged today again. That they had assured whoever that they were performing on all elements of care and they've had to pay back the money because they have been proven now not to. So how confident are you that our self-assessments are really accurate and that they would be borne out by an independent scrutineer, basically? Because I think it was headline news this morning.
I missed that, and we've done a lot of work over the last 6 months, I would say, in both neonatal and maternity. There is no doubt there is further work to do. I think we are in a positive position in that I think we've identified all areas where we have concerns and where we need to address those. So whilst not everything may be solved by the time the review comes, there will be no surprises because we have done a root and branch review. And that's across the clinical executives, and we meet weekly at the moment with the division and the maternity and neonatal team to try and make sure that we are continuing to drive those improvements forward.
Thank you.
It'll be interesting to see where the external review pitches its levels in terms of perfect versus pragmatism.
Yes.
I think that'll be the key to
Yeah.
it, and deliverables.
Yes.
That would be my personal interpretation.
Thank you, Andy. Can we move then to the Swansea Bay analysis assessment?
And I wasn't going to say very much about this, except that
it speaks for itself.
It speaks for itself. We've done the analysis. We've clearly identified our top priority recommendations that we need to take forward, we'll obviously take forward those as part of the existing maternity and neonatal improvement plans.
Right.
So we've done the gap analysis. I think it's really thorough.
Yeah.
And you know, I'm happy to take any questions, but yeah, we will take the recommendations.
Thank you. Are there any questions on it? I think it's a pretty thorough piece of work. Thank you very much to you and your team on that.
Sorry, Anne, can I just raise something?
Sorry.
Neonatal staff absence and the high rates. Want to comment on that?
Yeah, so
Staff absence, sorry, let's come back to the previous agenda item. I'm looking at page. Okay, there's no number on this one. Staff absence.
there is a higher than average absence rate in the neonatal unit. That forms part of the improvement plan and the listening event. It was one of the triggers for the listening events and for the work that my team and Sarah's team are doing about listening to staff.
Yeah, because I'm looking at work-related stress there, focus work being undertaken. I just wondered what can the board do to support that area of activity? Because obviously, if you've got somebody coming in nationally to look at the whole area, then
yeah. So we will shortly have the outcome of the listening review.
Right.
So we'll then pick up the themes, Paul, and obviously report that back through PQSO.
okay, thank you.
Thank you. Can we move on to 6.4 General Dental Services Reform Update and welcome, Laurie.
Just a very brief introduction. So the board will be aware that there's a paper attached covering off a number of issues in one paper. GDS, similar to GMS, is a pretty technical area. So with the chair's permission and grateful thanks for that, important that you have the experts, I think, to cover off a number of salient points. This is pretty fluid at the moment. It's undergone a consultation for some contract reform as well. And I believe that it was sort of announced in a plenary session as well yesterday. So it's pretty fluid, very topical at the moment, can be an incredibly noisy area for us, understandably, for our population and our patients. So Lloyd's just got a very brief presentation just to cover off a number of the salient points and highlight a couple of key areas for board, if that's okay.
Thanks, Leanne, for the introduction. And I have, so we listened to the plenary session, which was yesterday evening. So the last slide in this covers some of the key points from that plenary session, though just to caveat that the Health Board is still awaiting confirmation of the detail that's going to come out as a result of that. So I'll skip this first slide and just move on to sort of a high level overview in terms of the provision of general medical services within Aneurin and Bevan. So there is some detail or more detail in the report with figures associated with access levels, patients seen, etc. But as a high level overview, general dental services are currently provided and have been provided under the regulations from 2006, and part of the process has been working through the last 8 years a contractual reform which is culminating to the current position. So at present we have 72 dental practices operating NHS dental contracts under those regulations, and that spans the whole Health Board area. In addition to the general dental contracts that we have, we provide commission services which include our community dental services, which are targeted towards our vulnerable populations and or populations who have limited access to more routine dental services through health needs. Equally, we have then domiciliary care, orthodontic services, and a range of other services, including our delivery of dental services to Usk and Prescoid HMP. We, in addition to routine care, have emergency dental services, and they're broken down into two elements, so personal dental services and contract reform. We actively monitor those to ensure that the availability meets the demand, and actually we have had availability greater than demand for the last year or so, and we've just recently tweaked that to try and make sure that we are meeting the demand that's coming through as opposed to over additionality. The Dental Access Portal This has been in play within Aneurin Bevan since February. So since this slide was written, we have had an increase in terms of patients joining the Dental Access portal. So we're at 5,570 as opposed approximately 10 minutes ago. And during that time period since February, we've allocated nearly 1,800 patients to dentists within the Health Board. We have also offered an additional sort of 300 appointments where we either had no response or the offer has been declined by the patients. So I wanted just to flag that and ensure that there is additional detail within the paper. I'm going to cover in more detail the contractual reform because this is the sort of the biggest move in feast, as Leanne sort of described already. So on the next slide, this just highlights broadly the process and where we've got to from contractual reform almost to present day. So this started, as I said, almost 8 years ago with the publication and the working through of A Healthier Wales and the Oral Health and Dental Services response to that. And broadly, the rationale for the change was threefold. So to try and improve population health through improving oral health, the general well-being, and focusing on prevention as well as access to services. Enriching and improving the well-being capability as well as engagement of the dental workforce within Wales, and increasing then the value achieved from the funding that is received for dental services and programmes throughout Wales. And the needs-based approach, or that attempt to reduce oral health inequality, has been a key driver, and it's been worked through as a sort of the flagship element, which is the term the ACORN, which you can see on the side, which is around having a clear assessment of clinical oral risk and need, and then managing and working through the treatments and or review dates in line to that need. There was a pause, and a significant pause result of COVID-19, and the programme re-established then in 22-23, which has then continued to evolve. The next slide just highlights some of the key metrics. It has been a challenging time both for dental practices and the Health Board, because we have effectively been dual running services with the contract reform element, where practices have been able to opt into contract reform provisions under the metrics you can see on the slide. But we also have had what's deemed, I guess, as the traditional units of dental activity practice as well. So we've had performance measured against the activity under units of dental activity alongside that. So in terms of the dental services consultation, the next slide highlights the process and how that has progressed. So the dental services consultation was live, and we submitted as a Health Board a response in June, which was the deadline of this year. There's been a process in terms of reviewing the consultation responses, and there was, as announced yesterday, nearly 6,400 responses to that consultation and that process that we worked through within Welsh Government. The key changes that were originally proposed was around a single route of entry for people to access dental services, which is that dental access platform that I discussed previously. The implementation of the remuneration system that the Welsh Government were deeming to be more fairer and transparent, and trying to incentivise more acute need and management, and minimise unnecessary routine examinations, so bringing it more in line with the evidence base for appropriate review intervals. It requires regulatory changes, and the timeline that was previously sort of indicated was as described below. I've updated just to outline that the publication was yesterday, and obviously we're going through that response, but we haven't. There hasn't been a publication yet of the significant detail with some of the changes, but the plans are for those regulatory changes to be implemented in February, with the new contract to be enforced and brought into play from April, which is obviously a tight time frame for both the Health Board, but also population and our dental practices to work toward. The next slide covers the key sort of issues that were detailed in the consultation and in the report that you have in the papers. You'll see the response or the elements of all 14 metrics. So I'm not necessarily going to dwell on that slide. I was just going to skip to the next bit, which covers off the Health Board response. So the response that we provided within June, we gathered from across, obviously, the primary care community services division, as well as wider context within the Health Board system and our local local dental council. And we provided a balanced response that really highlighted the rationale for the change, which is around improving health inequalities, providing treatment based on risk and need, and the prioritisation of those with the greatest need first, so children and adults, were key elements that we wish to proceed and see come out of the new consultation, along with how we can have closer alignment with other primary care providers and the support mechanisms to embed place-based care approach. The areas of concern, and these remain areas of concern, are that the changes in any contract will and has resulted in some variations and terminations, which in itself can reduce access, and during that time, and it remains a certain element of this, there's a lack of clarity in terms of the specific detail for both health boards and contractors to effectively implement the services for our population. Next slide just covers a bit more detail, as well as our local dental committee's views. So the single route of access into the dental access portal does have a challenge around the continuity of care, so patients seeing the same dental practitioner, and particularly where patients have challenging confidence in terms of seeing a dentist and having that relationship with a dentist. It does bring some benefits in terms of processing and being able to map and manage the system, but it obviously doesn't bring with it as well an additional administrative load. The challenges that the local dental committee are in sort of fivefold, and they did provide their own response into the consultation, and it was around the direct access portal, some very technical details around the seniority payments, laboratory fees, and COPS, and some of the specific complexities regarding the fee scales as well. So in terms of outcomes and mitigations, which is the next slide, so there is still remains a high level of uncertainty, and that brings a challenge around the potential influx of contract terminations and reductions. To note that this year we have had 2 contract terminations. One is effective of September, so this month, and another will be effective from December. In comparison, there were 2 in the previous year as well. We obviously will be needing to consider alternative mechanisms for service delivery if we have contract terminations and reductions that are not able to be re-provided by existing or new providers. We have included it obviously within the risk register within the Health Board, as well as within obviously specifically this division, and we are working through as well some of the considerations around new regulations that came into play in February of this year around the procurement of health services. So they're called the provider selection regime regulations that came into place, and this came in place for all primary care contractors, but obviously it's the commissioning of a new GDS contract that will be a particular challenge that we'll work through with our NWSSP colleagues, so shared services partnership colleagues. So in terms of next steps and recommendations, so we are continuing as a division and as more broadly as a Health Board to manage and monitor all contracts in accordance with the existing regulations, which are those of the 2006 regulations. We link very closely and we meet with our both practices but also our local dental committee colleagues, and we will continue to apply the usual processes in place for any contract variations, terminations, and working through how we can develop going forward with our integrated oral health group. The detail, obviously, within the report is much more detailed than what I've covered for the purposes of time. But the next slide I just want to touch on, just as a sort of reflections from yesterday's plenary sessions. And as I say, apologies that the slide may not have the high levels of detail that we want, but some of that is because it hasn't come out through Welsh Government at present. So I touched on high level of responses, and it's key to note that there is a broad support for contract reform, so people feel that the underlying principles of why the reform is being brought through, i.e. improving access and those with the greatest need accessing the services, was broadly supported. It was confirmed yesterday as well that the new contract will be from April of 2026, and that, as I said, will bring individual patient oral health risk and need together. There is a postponement was announced yesterday in terms of the online payment system, so that has been suggested that it will be postponed until April 2027, and there has been a description of simpler dental charges for fee paying patients. Again, we're waiting for some greater clarity on that from the plenary session that was able to listen to yesterday evening. This was the detail that was received. The continuity of care, which we'd flag as a health board concern, and as I mentioned on my previous slide, was recognised from the consultation, and green patients, so these are patients with not active dental treatment requirements, so those will be not, they won't need to be they won't need to access the dental access portal again. They will remain with the practice that they had been allocated or are currently with as part of that process. There was confirmation that we will be having alignment with the accelerated cluster development that other primary care contractors have, but there was also the acknowledgement that we will need to develop a high needs pathway within the health board over the coming months. Some of the other elements that you can see there are elements that are more technical in terms of incentivising workforce and seniority payments and parental sickness leave, which is all associated with the dental workforce. But those, as I say, we will still expecting some greater clarity on in the coming weeks. So just to be clear, as I say, we're waiting for the clarity and confirmation of the detail. This is taken from the oral statement delivered by the Cabinet Secretary for Health and Social Care yesterday. And as I said, overarching, I think most of the views, if not all that have been from at least the Health Board response in, have been taken into consideration. We'll just be waiting for potential mitigations and how the practical implementation of recommissioning a dental contract across all our providers by April will be implemented by ourselves in the division and obviously the wider health board. So I'll stop there, and I'm not sure if there are any comments or questions, but welcome to answer anything that there is from the board.
Thank you very much, Lloyd. That was very helpful. Yeah, Leanne?
Just two very quick points from me. The first is just to say thank you to the board. I know the agenda is incredibly busy today, but obviously it's in line with Audit World recommendation of more visibility of primary care discussions at board. And as I said, because it is so topical, I also think it's important to note, Lloyd shared this fact in a conversation that we've had, but this actually generated more consultation responses than the 20-mile-per-hour speed limit. Yes. So I think just to set it in the context of, I guess, sort of public and professional sort of interest in this, really. And as Lloyd has already said, the devil will be in the detail, really. I'm sure that it would be very relevant for us to bring back, I guess, sort of an implementation plan when we are fully aware of all of the details, really, I guess. So they were just the two quick points we wanted to add.
It is complicated.
It is, yes.
It is changing by the day. Yes, and I think an update will be welcomed. Penny?
Yes, thank you. Hello, Lloyd. It was very interesting. I don't know if this is the right place to ask this or the right time. How will this affect, where will this leave and how will this affect looked after children? The ones who are constantly on the move, you know, between one foster care and another or whatever. how will they be accommodated within these changes?
Yeah, so I can't see who asked the question, but thanks for the question. So there's probably two elements to that. So we're still lacking the detail as yet from Welsh Government to be able to be clear on it. But from our perspective, we've got a couple of models in place in the Health Board to support and manage this cohort of our population already. So I mentioned broadly that we've got a community dental service that sits outside of the GDS regulation. So that's a service that's provided solely by the Health Board, and that is a service that's provided to vulnerable patient groups and those with complex needs and challenging access requirements. So that service is still remains, it exists, that will still continue with that. What the benefit will be is that if those population groups don't want to access that service in that way, the changes here should help support the prioritisation of complex adults with health needs, but equally those children as well. So it should hopefully provide an additional access point to ensure those patients or the population have access to our dental services.
Thank you, Lloyd.
Any further queries? We'll keep you very well updated on how things progress. But thank you, and I'm sure you're endorsing how the division is actually tackling this problem.
Day by day.
Thank you ever so much, Lloyd. Thank you.
Thank you all.
The strategic risk report.
Yeah, so I'll assume it's read. I'll just point out there's been two changes to the both changes to the risk register. One is to increase the risk relating to the financial sustainability of the Health Board. We did improve it last year, but we have partially increased it again, given the challenges we've discussed earlier. And the second risk that we have increased the rating of is around digital systems and some of the challenges we continue to face around implementation timescales of the RISP and the LIMS service and the risks that could present to us. So they were the two proposed changes to the risk register, and obviously the normal detail about how we're looking to mitigate those. Thank you. Any comments or concerns?
Comment. Paul's obviously been keeping me up to date with the progress on RIMS and LISP and the issues around those and risks incurred. Just to highlight that this obviously is not a simple case of a system being delayed that has ongoing impacts, both in terms of a risk to ongoing operations should be systems they are replacing fail, but also in terms of staff activity, because but for example on LIMS, the significant amount of testing that's needed to ensure that system is ready to go will be impacting not just our technology staff, but also the staff that will then have to use that system at the end of the day. And similarly on the radiology system, that'll have the clinical support services are going to be pretty overwhelmed with the amount of changes hitting them at the moment. So the fact that these services, both of these big national programs are facing delays and risks is really quite concerning. And obviously looking forward to picking up more conversations on those in Finance Performance Committee and separately afterwards.
And you're content with the risk level?
I have been encouraged that we increase the risk level. So yes, I think it's important, but as a board, we recognise this is a big risk.
Yes, it's a big risk. Not within our control.
Yes.
Are there any further questions? I think we've discussed it in the committee quite considerably. No? In that case, having adopted the consent agenda, is there any other business? No? The date of the next meeting is the 26th of November. I shall now move into the confidential agenda and exclude members of the